Sure. Well, we are now live on YouTube. We're ready to go.
Great, thank you. Call to order the meeting of the Public Employees Benefits Program Board scheduled for today, Friday, October 24th, 2025 at 9 a.m. Can I get a roll call, please?
Good morning, everyone. Starting roll call. Chair Wells,
Here.
Joy Grimmer. Joy? Okay, I know she's on, but Janelle Woodward,
Here.
Jennifer McClendon,
Here.
Jim Barnes,
Here.
Blaine Harper,
Here.
Christopher Vuitton,
Here.
Keiko Duncan,
Here.
Taryn Emmerich Choi,
Here.
and I'm going to try Joy Grimmer again.
Present.
Thank you. And Laura Rich is absent today. We do have a quorum. Please remember to state and spell your name for the online transcript. Thank you.
Thank you. We'll open agenda item number 2, public comment. No action may be taken on any matter raised under this item unless the matter is included in an agenda item on which action may be taken. Public comments to the board will be taken under advisement, but will not be answered during the meeting. Comments may be limited to 3 minutes per person at the discretion of the chair. Additional 3-minute comment periods may be allowed on individual agenda items at the discretion of the chair. Today, we are going to add agenda 8.4. We'll take public comment before the board actions on 8.4. These additional comment periods shall be limited to comments relevant to that agenda item under consideration by the board. Members of the public may make public comment by using the phone number 669-900-6833. The meeting ID is 812-3744-7363 #. Participant ID is #. Persons unable to attend the meeting or in person or telephone, and persons whose comments extend beyond the 3 minutes may submit them in writing. Do we have any public comment here in Carson City?
Good morning, Kent Irvin, KENT-ERVIN for the Nevada Faculty Alliance, the Independent Association of Professional Employees at our public colleges and universities. There are several important agenda items today. We appreciate that the PEBP policies and procedures are being updated. I urge board members to review the sections on the duties of the board and staff. The proposed changes, however, do not entirely address the changes due to Senate Bill 494 of the past session. For example, 1, the executive officer now serves at the pleasure of the governor rather than the board. 2, the scope of the study of Medicare exchange retiree benefits per SB 494 is both broader and more specific than in the proposed language. And 3rd, the procurement procedures need to clarify when state purchasing will be used versus the new Nevada Health Authority procurement process. The rate setting protocols in the appendix should be more detailed and updated, including how rates and employee contributions for dependent tiers are set. We now have the final budget as of the close of fiscal year 2025. The actuarial mandatory reserves were $55.4 million for IBNR at 95% confidence, $47.0 million for catastrophic at 50 days of claims, and $20.6 for the health reimbursement arrangements at 80% of balances. That totals $123 million. The cash on hand dropped to $67 million at the final closing, which means the reserves were deficient by $56 million. That's more than we thought at our last meeting. The reserves deficit drops to $51 million for FY 2026, but only because Siegel calculated the catastrophic reserve at 45 days instead of the written board policy of 50 days. How quickly does PEB plan to replenish the reserves? That needs to be addressed before determining any plan design changes for FY 2027. For the plan design discussion, our highest priorities are maintaining current benefits and holding employee premiums in check as much as possible. If there are funds available because of the large increase in the state contribution per employee, then it's time to restore benefits to pre-pandemic levels. We don't understand why there is cross-subsidization between the self-funded plans. PEB policy states all the plan options are underwritten as a single risk pool. So were the rates set differently from that policy, or has recent migration caused it, or some other reason? Regardless, the three plan options should be tweaked to be better differentiated for participants and of equal cost per actuarial value. Finally, I would like to welcome new board member Taryn Emmerich Choi, and we look forward to the governor's appointment to the remaining vacant position and to the Northern NC representative position whose original term has expired. Thank you.
Dr. Urban. Any other public comment here in Carson City? Any public comment online?
You have about 7, Chair Wills. Is it all right if I bring up the slide? Can you switch that? Perfect. One moment, please. Joining the Zoom meeting as an attendee is for making public comment only. If you do not wish to make a public comment, please leave the Zoom meeting now so you're not accidentally called upon. Please feel free to watch it via the YouTube live stream on the PEB YouTube channel. The link for the live stream is located on the agenda. For those who have joined for public comment, your name or the last 4 digits of your phone number will be announced. You have been advised you have been unmuted. Please slowly state and spell your name for the record and then proceed with your comments. Douglas Unger, please slowly spell or state and spell your name for the record.
Doug Unger, D-O-U-G-U-N-G-E-R, immediate past president, UNLV Nevada Faculty Alliance, and member of the UNLV Employee Benefits Advisory Committee. Thank you to the chair and the board for your service and consideration. Regarding the Siegel report on medical and prescription drug performance of PEB health plans, I'm concerned that the CDHP plan is in effect subsidizing the other plans, which should not be happening under PEB rules and past practices, which requires a single risk pool across the 3 self-funded plans. Has PEB policy changed, and why? I am also concerned that Siegel seemingly proposes to examine the HMO and EPO plans once again for possible elimination. Please note that the HMO plan in the South is performing well and is in fairly consistent demand. Employees like it and rely on it, and that there will be very loud and impassioned pushback should that plan be considered for elimination. Clearly, the EPO plan in the North is an issue, but it makes no sense to sacrifice a satisfactorily performing HMO in the South to a possibly failing experiment in the North. We appreciate many of the suggested enhancements in the Siegel report and the clarity of this report overall. Thank you. Enhancing the vision plan would be especially well received. However, let's keep in mind that restoration of a long-term disability benefit is, to us, a more urgent and pressing issue, and we would appreciate the board considering this possibility. Finally, it's clear by the Siegel report that the prescription drug inflation cannot be sustained. Still, I note that the prescribing of expensive weight loss drugs is increasing exponentially. I'm wondering what a more detailed analysis of the cost of weight loss drugs on this pharmacy benefit inflationary trend might be, and if the board might consider a carve-out with perhaps higher copays for this class of medications to lower the overall inflationary trends. Thank you all again for your service, and thank you to Siegel for the clarity of their report. We look forward to working with you all as future plan designs come into sharper focus. Thank you.
Thank you, Dr. Unger.
Well, Claudia, you have permission to speak. Please slowly state and spell your name if you wish to make public comment. Let's see. Joe Ferrari. You have permission to speak. Please state and spell your name for the record if you wish to make public comment. Caller with the last 4 digits 0891. You have permission to speak. Please slowly spell and state your name for the record.
Thank you. Good morning, Executive Officer Karsten, Chair Wells, fellow board members and staff. My name for the record is Terry Laird, Terrilaird. I'm the Executive Director at RPEN, the Retired Public Employees of Nevada, a nonprofit, nonpartisan group created nearly 50 years ago to protect the pension and healthcare benefits earned by all public employees, those still working as well as retired. We had hoped, as you remember, to see a $2 increase approved this year in the health reimbursement arrangement, HRA, for retirees in the Medicare exchange. Although it didn't happen, we do hope it can be considered again during the next session in 2027. This is especially important as we learn about the large increases in Part D pharmaceuticals and the many other Medicare plan hikes proposed during open enrollment this fall. Most of our members are living on fixed incomes, not the Cadillac retirements often brought up by groups who believe public employees have excessive pensions and health benefits. At the same time, we do know PEB faces many challenges, and we appreciate any and all efforts you make on our behalf of these hardworking employees and retirees. The PEB staff has always been eager to help when RPEN brings our members' concerns and/or problems to them. I also would like to thank your new Executive Officer, Teresa Karsten, and Cara Tibiduiza, PEB's Education Information Officer, for taking time out to speak to RPEN's Board of Directors Convention held last month in Reno. Nearly 100 members that attended had a lot of questions about PEB and the new Nevada Health Authority, and these ladies had all the answers. I also thank Teresa, who was just starting her new job, for pulling together a Health Matters column for RPEN's September-October review newsletter that is mailed to nearly 7,000 members statewide. I was very impressed that she was able to get it done. So again, we thank you and look forward to a successful collaboration going forward. Thank you.
Thank you, Ms. Laird.
Caller with the last four digits, 8673. You have permission to speak. Please press *6 to unmute, and please state and spell your name for the record.
Good morning. My name is Brooke Maylath. That's BROOKEMAYLATH. And I'm calling to share some very deep concerns about the inadequacies of UMR in handling the appropriate coverage for mandated coverage of gender-affirming procedures by Nevada statute and under the policy for PEB, specifically seeking a gender-affirming procedure in Northern Nevada for a fairly common procedure. I have gone through 4 months of the circular argument by UMR with all of their different divisions, including pre-authorization, including customer service, including their plan benefits side and provider relations, all of which are essentially getting to the fact that even though that they have certain providers that are in network, none of them cover the procedures of what we're talking about in Northern Nevada. Nor does there seem to be any willingness for these providers, because of the typical runaround by insurance companies in general, of being able to set up any sort of plan to be able to cover these things. The issue with UMR is that they've got multiple different departments that don't know what each other are doing and are setting up this circular reasoning that if anybody's been through the process of, oh, we don't cover this, you can be able to pay up front, we'll be able to reimburse you at 140% of Medicare rates, but we don't know what all of those different reimbursements are going to be, so we can't give you a number. Essentially, the largest insurance provider in the country is saying, we don't know what the average reimbursement is going to be for anything. This does not serve the PEB members or the PEB organization a good way to be able to manage costs, to be able to service their members, to be able to have a workforce that is healthy and productive and can be able to focus on their jobs in the best manner possible. When it comes time for renewal, looking at the service that is being provided by UMR is under these circumstances is definitely something that needs to be done. In the meantime, I would really recommend that the PEB board recommend to UMR to either get into direct negotiation with providers to be able to provide these gender affirming procedures and the coverage thereof. My back of the napkin calculations indicate that there will be cost savings to PEB by doing so, as opposed to going on their 140% of Medicare rates. Fortunately, I do have experience in being able to calculate these things, which seems to be superior to the information that I'm getting from UMR, which is extremely unfortunate. I will submit this information with more details in writing as soon as I have an opportunity. I look forward to potential action being taken on this, and I thank you for your time.
Thank you, Ms. Mela.
Looks like we have Claudia. Caller with the last four digits 9199. You have been unmuted. Or please, if you have permission to speak, please unmute your phone and please slowly state and spell your name for the record.
Good morning, Chair and members of the PEB board. I appreciate the opportunity to speak to you all today. My name is Tess Opferman, that's spelled O-P-F-E-R-M-A-N, and I'm speaking on behalf of the AFSCME retirees. We represent retired state workers here in Nevada. I know there's been quite a shift in the board over the last few months, so I wanted to give some background on the challenge that our retirees have been facing. In the board duties and updates, you will see a board duty that was added through SB 494, and that states establishing programs to ensure the provision of high quality customer service to assist participants in navigating the benefits available under the program. I wanted to give you a little bit of background of why that was included in SB 494. That was actually a request on behalf of the retirees and RPEN and some of our partners. And that's because our retirees have been facing some challenges with customer service between PEB and through VIA benefits. Just this morning, actually, I got an email from a board member. She reached out to VIA benefits to review options for supplemental plans and pricing before open enrollment starts. Her meeting couldn't be set for under 4 weeks out, so it was set for 4 weeks from now, which just seems excessive. We don't understand why it would take so long to get a meeting to review your supplemental plan. That's almost a month out. How many retirees are staying with their current plan even if costs go up because it's cumbersome to make the calls and have to wait and navigate the website? Other members have struggled with using their health reimbursement arrangement, the HRA. They call PEB and are told they need to talk to VIA benefits. They call VIA benefits and talk to representatives that don't understand the health reimbursement arrangement and are then told they need to talk to PEB. Last year, I asked for our contact so that I could try to navigate the system. I was curious what our retirees were facing. I was told, yes, there's a person you can talk to. Here's the phone number. I called that phone number, asked for the person. There was no person by that name. They were confused about their role. I told them, hey, I was told that you could be a direct contact that my retirees could reach out to get some direct support. And they said, no, that's not what this line is used for. We're unclear on why you are asking for that. So all to say, we've got quite a few examples of where our retirees just don't have a person they can talk to and then aren't able to use their HRA reimbursement account. And I think that is part of why we're seeing that many retirees don't even use that account. It's just so cumbersome to use. So I wanted to give you a little bit of background on that very specific challenge we're facing. I know that there's a number of new board members, so I'm hopeful that in the next couple of months, this is something that you would be willing to look into and help our retirees get a little more customer service. Thank you so much for your time today.
Thank you, Ms. Offerman.
Let's try Claudia. You have permission to speak. Please slowly state and spell your name if you wish to make public comment. Very well, as that concludes public comment.
Great, thank you. We'll close the first public comment period and move to agenda item number 3, PEB board disclosures.
Thank you, Chair Walls. Good morning, everyone. My name is Radhika Kanal, Deputy Attorney General for the record. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for Public Employee Benefits Program, PEP benefits. Pursuant to NRS 281A.420, on behalf of the board members who are eligible for PEP benefits or whose families are eligible for PEP benefits, I offer this disclosure that they will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEP benefits. At this time, I invite any member of the board who has any additional disclosures to make them now. Thank you.
Thank you, Ms. Cornell. Close agenda item number 3. Open agenda item number 4, approval of the action minutes from the July 31st, 2025 PEP board meeting. There are no changes to the minutes. I'd accept the motion to approve them.
Jim Barnes, so moved.
And a second.
Joy Gerber, second.
You lead out, Joy. We have a motion and a second. Can I, all in favor, say aye.
Aye.
Any opposed, nay? Motion passes. Close agenda item number 4. Move to agenda item number 5. I asked that agenda items number 5 and 6 be placed on today's agenda. We've got a lot of new board members here. We've got new staff. I thought it was a great opportunity to take a look at what the board's duties and responsibilities are, as well as update policies and procedures that have not been updated since 2021. I think that we probably need to look at some additional changes to the duties, policies, and procedures as we move forward. One of the things that's mentioned in the duties, policies, and procedures talks about a strategic plan. I do not know the last time the strategic plan was updated, but at some point in the very near future, we'll be setting a date to have a discussion about the PEP strategic plan, recognizing that now the PEP is part of the larger health authority, making sure that everything is in alignment between the health authority and the PEP strategic plan. So with that, we'll start with kind of an overview of what the board's duties and responsibilities are as they were updated from SB 494 in the 2025 legislative session. Mooneyhan.
Thank you, Chair Wells. For the record, my name is Brandy Mooneyhan. I'm the insurance counsel for PEP. Like Chair Wells said, this is going to be a general overview of the board's duties and powers and where those come from, the authorities for those duties and powers. We're not going to go into a lot of detail today, but if there are any items that raise interest that the board would like to see an in-depth presentation on, we can definitely make arrangements for that at a future board meeting. There are 3 main places where the board's duties are set forth. That's the Nevada revised statutes, the Nevada Administrative Code, and the policies and procedures, which are going to be discussed later this morning. PEP was created by the legislature in Chapter 287 of the Nevada revised statutes. There are several hundred chapters in the Nevada revised statutes, and all of those, as well as the regulations arising from them, are available on the legislature's website. And Chapter 287, because it applies to PEP, is available on PEP's website if you want to look at those in depth. We're going to talk about the ones applying to the board today, but there are many other areas covered in the Chapter 287. For example, how local governments can arrange for health insurance, all kinds of details about the maintenance of the funds underlying the program and how it's administered. And even the state employees deferred compensation program is set forth in Chapter 287. So there are a lot of areas we're not going to talk about today, but so when you go look at the statute, you'll see that there are many aspects in there. As Chair Wells pointed out earlier this year, when the Senate passed, or the legislature passed Senate Bill 494, created the Nevada Health Authority, placed PEP within it. SB 494 is also available on the legislature's website. It's a very comprehensive bill. and it affects many aspects of healthcare in Nevada. It's about 270 pages long, and I'm not going to go into great detail about it today. But it does have a lot of interesting aspects, but in general, the main thing to know about it as it applies to PEB is that it was created to improve access to healthcare, improve quality of healthcare in Nevada, and minimize cost of healthcare coverage to the extent possible. Contemplates a relationship between the health authority and PEB, the PEB board. The health authority can talk to the PEB board for about ideas about how to achieve those aims, and the board can make recommendations to the health authority. So I imagine that we will be seeing that in the coming board meetings. Some of the specific statutes that set forth requirements for the board. It talks about how many members of the board, where they're drawn from, the qualifications. SB 494 did make a small change to that. All members used to be appointed by the governor. Now 2 members are appointed by legislative leaders. The bill also changed how the board chair is chosen. The governor used to appoint the chair. Now the board chair is elected by the other members, and the governor appoints a vice chair. And as you know, our chair is Jim Wells and our vice chair is Dre Grimmer. The statute requires that the board meet at least once a quarter, and of course, the chair can call it more often than that. For the last several years, it's been approximately every other month, 6 or 7 times a year, with more during legislative sessions. The board needs to comply with the open meeting law, which is set forth in NRS Chapter 241. The Attorney General's office enforces the open meeting law, and we rely on them for ensuring that we comply with it. That's why Ms. Cannell is here to make sure that the board does comply if we have any questions. The board may also appoint advisory committees or subcommittees if it desires to research any specific questions. With respect to the relationship between the board and the executive officer, somewhat similar to the corporate structure that many people are familiar with, the board determines the overall strategy for the program, while the executive officer is responsible for carrying out that strategy on a day-to-day basis. The executive officer reports back to the board regarding the implementation of those strategies. SB 494 added reporting to the director of the Nevada Health Authority, so that the executive officer can assist in the mission of the authority that we talked about earlier. For example, innovation and leveraging resources, and hopefully buying power of the different agencies involved in the Nevada Health Authority. One of the key aspects is set forth in that relationship is set forth in NRS 287.0424 subsection 1, and that is encompassed in the policies and procedures that you will talk about later. The board can delegate to the executive officer the exercise or discharge of any power, duty, or function imposed. So it's important, the statute sets forth the duties of the board, and you can delegate all of that, some of that, to the executive officer, and that's traditionally been encompassed in those policies and procedures. Those were last revised in January 2021, so I know that there are potential revisions. And on today's agenda, with the contemplation that maybe more revisions will be set forth by the board soon. The statute also requires certain reports be submitted to authorities on a periodic basis. The executive officer is responsible for many annual reports and biannual reports, including audited financial statements, utilization, and the materials that are presented to the members. So you will be seeing those periodically throughout the year. PEB also does every other year a compliance review to make sure that it's compliant with all federal and state laws that apply to the program. And SB 494 did add a new biannual report to the duties of the board to the extent that it can, to the extent the resources are available. The board is now charged with compiling a report regarding the cost for retirees to obtain Medicare coverage through PEB, and that is actuarially comparable to the coverage provided through PEB that is not for Medicare. The report will go to the IFC, presumably for them to consider future legislative changes. That first report is due next August, and then it is due every other year after that, barring any future changes. Another important statute in Chapter 287 is 287.043 that addresses the elements of the program. And that's where the legislature gave the board the duty to carry out a program that includes life, accident, or health insurance, or any combination of those three. It allows a lot of flexibility in the plan and for the plan to make arrangements for certain benefits to be paid on a pre-tax basis. This is pretty much section 043 is where most of the board's power to act comes from. It also gives the board the responsibility of making sure that PEB is funded on an actuarially sound basis and that it's operated in a sound insurance and business in accordance with those insurance and business practices. One of the very nice things about SB 494 is it allows PEB to use the actuarial and other resources or contractors that the Nevada Health Authority and the other agencies, the Nevada Health Authority. So that gives PEB access to more resources to be able to carry forth that duty. Section 043 also allows the board to adopt regulations to carry out the program. We'll talk about a few regulations that apply to the board, but those are set forth in NEC Chapter 287. So they match up, and that's also available on PEB's website and the legislature's website. Up until July 1st of this year, the statute allowed PEB to use the state purchasing division to procure services and contracts to carry out the program. SB 494 sets forth, it provides that PEB can still use state purchasing, but there's also a new procurement procedure that the health authority is working on establishing. That's still a work in progress because, as you can imagine, that's a pretty big lift. But once those are established, PEB will be able to use either, depending on, and it may be discussed, as was hinted at in public comment, the board can figure out when they're going to use which. In general, once those services are up and running from the health authority, it may help PEB carry into effect the purpose of the health authority, which is to leverage purchasing power with other agencies for some of the services that are consistent with all of the programs within the health authority. Right now, of course, we're still using state purchasing as we did before and still pursuing contracts and doing all the normal procedures. That statute, section 043, again, it's a big, dense one that has a lot of information in it. It also allows the board to make recommendations to the legislature for necessary legislation regarding PEB. So that is what gives the board the authority to go to make recommendations and suggestions during the next legislative session. There are also several statutes within Chapter 287 talking about specific treatments and specific procedures, specific coverage that is required by the legislature. There's all kinds of different screenings and vaccinations and testing. One that there are specific statutes, for example, like NRS 287.0.273 talks about coverage for mammograms. 272 talks about coverage for HPV vaccinations. 271 talks about HIV. So there's quite a list. Then there's one statute, NRS 287.04335. That has a few dozen requirements that apply to PEB. It's essentially a list of numerous other statutes, other chapters that PEB has to comply with. For example, NRS Chapter 695G governs managed care, and there are several provisions in 04335 in PEB's Chapter 287 that lists provisions of 695 with which PEB must comply. So, for example, one of the ones that PEB has to comply with is NRS 695G.170. When you look at Chapter 287 287, there's not any provision about emergency services, but PEP does need to provide coverage for emergency services because it must comply with NRS 695G.170, which is one in that list, a long list of statutes with which PEP needs to comply. There are a lot of changes to that through the legislative session, as you can imagine. The statute also allows the board to enter into contracts. Again, it's very similar to the previous provision about entry into contracting for services. Later in today's meeting, just like in all meetings, you'll get an update on PEP's current contracts with its current vendors and where they're at, their status. Again, historically, we've gone through state purchasing and continue to do so, but that may change in the near-ish future. PEP has a special exception to general purchasing rules and that the board can review the results of an evaluation of RFPs. It's in NRS 287.04345. The evaluation committee might look at many different vendors and then they choose one. The board can, at one of its meetings, look at that evaluation, hear about how the vendor was chosen and the different vendors that did provide a bid. If it does, that is one exception to the open meeting law. For that discussion only, the board can have a closed meeting. We've done that several times. But any action, of course, on the contract will be taken in an open meeting, just consistent with the open meeting law. Another chapter besides chapter 287 that applies that the board members need to be aware of, Ms. Cannell referred to it briefly, was NRS chapter 281A. That contains the Nevada Ethics and Government Law. The Nevada Commission on Ethics is the one that administers the ethics law. And the board member should be aware that when acting as a board member, you are public officers, as that term is defined in the ethics law, and this you're subject to the provisions of the ethics law. The Ethics Commission's website, it's ethics.nv.gov. It is very robust. It has a lot of information. They've issued many opinions. Public officers can ask about certain activities they want to engage in, they're hoping to engage in, whether it violates the ethics law. So they have a lot of those opinions available on their website. And they also have a training module that public officers can register for and become very familiar with the different aspects that apply to you as a public officer. In general, of course, I'll give you a broad overview, but I would recommend the training on the Ethics Commission's website. But in general, you can't use your position as a board member to further a private interest of yourself or a person with which you have a close relationship, like a family member or a close friend, or accept something that would tend to improperly influence your vote, your discharge of your duties as a public officer. And you heard the exception that Ms. Cannell stated at the beginning of the meeting, that of course, that doesn't prevent you from voting on benefits, even if you are a recipient of PEP benefits. One of the very nice things I think for the public officers is that NRS chapter 281A provides a safe harbor provision. So if you in good faith rely on the advice of counsel in carrying forth your duties, that does provide a defense to an ethics complaint. So when in doubt, give myself or Ms. Cannell a call. We can help you research those provisions, maybe talk to our colleagues at the Ethics Commission, and so that's definitely available to you before you vote on something if there are any doubts whether it might violate the ethics law. Like I mentioned earlier, the board can carry regulations. These are a lot more detailed than the statutes. They go into great detail about who's eligible, how to file an appeal if a member doesn't like the decision on one of their claims, and a lot of other details. The nice thing about the regulations, it gives the board the chance to clarify details, define terms. They're a lot more flexible. They can be changed more quickly That's relative. They can be changed in months instead of years. But it does give you the opportunity to address that. Those are also available, of course, on our website. Frankly, they need to be cleaned up with the passage of SB 494. There are some that have been mooted. They don't make sense anymore. And there are also some changes that have been made to the open meeting law that have made some of our regulations redundant. So we are working on suggestions for the board's consideration at a future meeting for a revamp of the regulations. But the ones that you should know about today, I made some errors on slide 19. I apologize. One of the citations there was about the board. The chair does still determine the agenda of the board, but the citation for that is NAC 287.172. I think I put 174 on the slide. And of course, any member can request that a matter be placed on the agenda. So again, if anything today raises an issue that you want to hear more about, you can make a suggestion to the chair that we do a deep dive in the future. The slide also points out that action must be approved by a majority. Again, that is one of those things that is somewhat redundant because that's set forth in the open meeting law. Similar requiring a second, that is the regulations provide for that. That's not necessarily required by the open meeting law, but the board can decide if they want to make that part of their procedure. But those are some of the things that apply to the board. At the beginning, I said the NRS, the NAC, and the board's the policies and procedures are kind of where the board's authority and responsibilities are set forth. I'm not going to go into any detail about the policies and procedures because you're going to talk about that in depth in just a moment. But if you have any questions, that concludes that presentation for today. But if you have any questions about that or suggestions for areas you would like a deep dive on in the future, please let me know.
Thank you. Any questions for Ms. Mooney?
Keiko Duncan for the record, just a very simple question. In the powers and duties, it says that we may use the state purchasing division in procuring services or the new services established by the NVHA for such procurement. Is that like a voting item for the board? Does the board decide on the either or?
Well, the statute, of course, allows either. And of course, I think that that's up to the board to decide. That may be part of the policies and procedures. It's not set forth in the statute that that's exactly how you'll do it. So I think it's up to your discretion. And so that is something you can talk about. If you wanted to, you could make a list of here's the ones we definitely want to use the NVHA. Here's the ones we definitely want to use state purchasing. You may give parameters to the executive officer to carry forth. That's definitely up to the board's discretion.
Thank you.
Any other questions? Great, thank you. Close agenda item number 5, move to agenda item 6, discussion and possible action regarding the board's policies and procedures document. Ms. Biddle.
Good morning, Leslie Biddleston, Quality Control Officer for the record. Agenda item number 6 is the board duties, policies and procedures that was last updated January of 2021. As you heard from Ms. Mooneyhan, a lot of changes have been made legislatively since this document was updated. There are still some things in the works. For example, Nevada Health Authority has not yet completed their regulations around their contracts. So there's still a piece of this that has not yet been touched that will be as soon as we get some more information on from the Nevada Health Authority on their contracting process to bring back to the board for them to determine whether Nevada Health Authority contracting process or purchasing contracting process will be used. We are also pending a chief financial officer. There is a large section in this document that is fiscal. So we do need that piece by a fiscal expert, which is not me. So anyway, So to prepare for today's meeting, I did a very high-level review of this document to try to capture all of the legislative changes within this document. And unfortunately, I did miss a couple, so I do want to go over those sections that were changed and that I missed for the record, if you would like to follow along with me. So as you can see on page 3, just to let you know how this document is laid out, nothing has been removed. The items for removal have been lined out. All of the links to NRS or NAC were removed and hyperlinks were inserted. So all of those were removed. The appointing authority, as you heard Ms. Mooneyhan say, the appointing authority has changed a little bit in SB 494 from the governor. So now the Senate Majority Leader and the Speaker of the House now have some say in a couple of board members. Moving on to page 5. I do want to point out a typo. My apologies for the typo in number 11. Senate Bill 494, what is there is 2005, that should be 2025. Okay, moving on to page number 6. Under D, Executive Officer, Agency and Administration, the second sentence where it says the executive officer reports to the board, that is reports to the board is crossed out. The new language will read, the executive officer serves at the pleasure of the governor, appointed by the director of Nevada Health Authority and interviewed by the board, who makes recommendations to the director of the Nevada Health Authority and the governor. That is one part that I missed, but that is changed per SB 494. Moving on to page number 10, just above letter G, there is new language that says information regarding sexual harassment is located within a Department of Human Resource Management. That is incorrect. It should say Division of Human Resource Management. Okay. Moving on to page 15. Something that we heard earlier from public comments in the second paragraph, where it says the IBNR reserves will be funded at 95%. In the second sentence, the catastrophic reserves will be funded at a level of, it says 50, that should say 45. So that will be changed. And moving on to page number 19, letter B, under program reporting, self-insured plan utilization reports, PEB's chief financial officer. So chief financial officer will be removed and third-party administrator will be inserted. Moving on to Appendix A, the first page, and there is some formatting on this appendix that will be cleaned up for final approval. But on page Appendix A, first page, under the third bullet where it says benefits other than medical, prescription, and vision, the third check mark, long-term disability, that is removed. So scratched out there. And then moving on to, on the document says page 4. First bullet, I think that's the first bullet, where it says reserves. Same thing, catastrophic reserves will be changed from 50 to 45. So those are the items that I missed. So I wanted to read those in for the record. And as I stated, this is a first draft. There are more changes and more work to be done on this, but this is just presented to begin the discussion for the board. Take any questions if
Great, thank you. Are there any questions for Ms. Biddleston on the changes to the draft document?
Sorry, Kicker Duncan for the record. I was just curious, what is the source of the 45-day, 50-day change?
Leslie Biddleston for the record. This was a previous board decision that I believe, and maybe Ms. Mooneyhan can correct me. Is that correct? A previous board decision? Yes, okay. I don't know exactly when the board decision, but that's why it was corrected, because it was a decision by the board.
For the record, has that 50-day time frame been changed from a previous number? How long has it been 50 days?
Leslie Biddleston for the record. Unfortunately, I can't answer that. I do not know that. I can do some research and bring that back to a future board meeting if that is what the board desires, but that I cannot answer today.
Any other questions? Okay, so let's walk through the document a little bit and see if there are any other changes that the board members would like to propose to the board's duties, policies, and procedures. I think section 1, the introduction, is pretty straightforward. Section 2, the appointment authority, has been changed to reflect Senate Bill 494. Section 3, governance, starts kind of with the framework and the board responsibilities on page 4. Other than the removal of links, it looks like, and some changes to the interview and recommendations for the approval or the appointment of the executive officer. Let's see anything there. Any questions on section 3, governance in the board responsibilities? B, board member conduct. Questions on board member conduct, section B. Section C, board meetings. Meet not let, page 6, number 1, meet not less than once every calendar quarter. We will probably meet, I think Ms. Mooneyhan said we generally meet every other month. That will probably be the minimum that we will meet over the next year. Next year will be a big year. You'll have a budget due, you'll have rate setting in the spring. We'll have strategic planning session at some point. So my guess would be probably more than every other month, probably 2 out of every 3. Any changes for section D, the executive officer and agency administration? Section E, ethics. And section F, sexual harassment. I believe in the past, we've had the chair of the ethics commission come in and give annual training to the board. We will probably set that up also for sometime in the early part of next year. I think that we've also had HIPAA training in the past to the board on a regular basis. We'll want to schedule HIPAA training, especially we have so many new members. We'll want to schedule a HIPAA training for the board. Confidentiality, travel. Section 4, contracts. I think that we will have some discussion as the health authority sets up their procurement regulations. I think the idea was that some of the contracts will be joint And that I think those ones who will be joint will be the ones that we will want to look at, whether we go through the health board and join with the fellow divisions for the health authority as we do some of the new contracts. I think that was kind of my thoughts on that. The PEB specific ones would continue to go through the purchasing office. Anything where there's joint, where we would be using the services along with other divisions of the health authority would go through the health authorities once it's set up.
So, kick it up for the record, thanks. So do we want to wait on changing some of our procurement policies until that NVHA procurement division is established, and maybe we'll reevaluate this item?
Yeah, I think once the health authorities regulations are approved for their procurement process,
Yeah.
then we'll want to revisit B, section B here and outline that.
Yeah, I agree.
Teresa Kirsten for the record. I also just want to put out there for you guys that it may depend on how Department of Division of Purchasing under DOA is funded, because I know they're talking about, you know, how certain funding had been funded for positions over there, and as the health authority establishes and gets up and running, some of that funding might be pulled back. So that might impact how many PEB projects based off of staff that they have left or funding that they have left for resources. So I think waiting to and including that in our analysis would be a good idea.
Yeah, definitely more to come up. And then C amendments, where I think there's a board item here about talking about contract amendments today. The section 5 is the premium and the rate setting process. This section, I think, was referred to in public comment, where we talked a little bit about the plan, setting the rates for the plan. Really, the idea, speaking from historical knowledge, the idea behind this document was that in general, the document would be static, but the appendix would be updated more regularly to reflect changes in the rate setting and that you would do more on an annual basis. That was the idea behind having the appendix carved out. So we will be looking more in depth at the appendix before we get into the rate setting process early next year to make sure that that aligns with what the board's desires are. The reserve policy, there was a question about the 50 days. I cannot remember exactly what the original version of the catastrophic reserve was. Catastrophic reserve dates back to 2003. So before 2003, there was no catastrophic reserve, but the plan had been bailed out a couple of times by the legislature, putting in supplemental dollars. So the idea was that the catastrophic reserve would be a reserve that would prevent the board or the plan from having to go back to the legislature for supplemental funds. So it's kind of got a dual purpose, so that it's there to offset if we have catastrophic claims. So if we have claims that are above that $2 million mark that the plan has, it's there to kind of offset those, because those are not necessarily built into the rates. And then the second piece was to make sure that we didn't have rates that skyrocketed from one year to the next, that we would be able to burn down and rebuild that reserve as necessary. So that was the original 2003 reason for putting the catastrophic reserve in. I cannot recall exactly. The IBNR at 95% has, I think, stayed the same since the beginning. But I don't remember exactly how the original catastrophic reserve was calculated. Now it's at 45 days, so basically a month and a half's worth of plan expenditures. Definitions shouldn't change significantly. Subsection D, the overview of the biennial process. So you've got the rate setting process, so you start with plan design, forecasting costs, forecasting premiums, adding in the fixed expenses for the operation of the board. in the department or the staff. And then any adjustment to the reserves and demographic changes. So that's kind of what we'll do as part of the rate setting process. That's kind of how it goes. You know, starting in November, we will finalize any additional plan changes for the 26-27 plan year. So that they can be costed in and included in the rates that we'll discuss in the spring. The strategic planning on page 18. We're supposed to review it, revise and approve it on an annual basis. Generally, the idea was that would be done before we had the discussions on plan design. As you have your strategic plan, that would guide where your plan design changes are coming from. It's a little bit late, so I think that the idea, for us will be to kind of update. I'm not sure exactly when the strategic plan was updated last. I know these haven't been updated for 4+ years, almost 5 years. So I don't know when the strategic plan was last updated, but my guess is it probably needs to be looked at as well. Next year, we'll start the budget process and the legislative agenda. So any legislative change, any legislative request, so language that is non-financial will have to be submitted to the legislature. I think the date's May now. That we have to have those over to the governor. So if there are any legislative changes that we want that are non-financial related, so financial related legislation will go through the budget process, but non-financial legislative changes, if there are any that we want to talk about, will need to be approved by this board and submitted before April. Program reporting. I've noticed over the last few years, there's been a consent agenda where a lot of the reports are put under the consent agenda. I think we've got such a new board, and I think at least for the first few reports, we're gonna have the people who prepare the reports present them and kind of highlight what they think are the key findings in those reports, so that we can kind of get an idea of what we're seeing as opposed to just having to read it and try to guess and ask questions. So I don't think, so that's why there's no consent agenda on this agenda today. This is kind of the first of the agendas where we will be talking more in depth in some of the reports that are provided to the board. After today's meeting, where we will kind of have a discussion, agenda item number 8 about possible changes to the plan for 26 and 27. Those will be brought back. The costs for those items will be brought back to us by the actuaries in November. So we will have an opportunity to see what those are cost before making a final decision. So even though we may be deciding today to have the actuaries look at what things cost, we're not saying today that they're going to be added to the plan design for 26 and 27. That won't occur until next month. Plan design. So now we're moving into the Appendix A. The Appendix A talks about plan selection options. So that's where you have your 4 plans, your CDHP plan, your EPO and HMO plans, and then the low deductible plan. You've got the individual Medicare market exchange for those who are eligible. Then you've got your other benefits, your dental, life insurance, health savings and health reimbursement arrangements, flexible spending accounts, and then all the voluntary. So I believe Ms. Biddleston talked about removing long-term disability from page 1, but it is still, I believe, a voluntary benefit. So it will need to be added at the end of that list. After short-term disability, there'll be long-term disability voluntary fully insured product. Some of the others, the homeowners, accident and indemnity, identity theft, buy-up, pet insurance. When we get into cost projections and rate development, so the kind of the next two sections. So this really talks about how we set rates. And the idea behind the original document was that it would be mathematical. So we would set the policy, and what the policy would then generate rate tables. So that there wouldn't necessarily be a lot of, well, we want this rate, this plan to be less, and this plan to cost more, or this tier to be less. It was really identified to kind of say, okay, this is what the plan costs. This is how the tier buckets are calculated for each of the plans. And this is how the state is going to subsidize those plans. It's kind of changed a little bit over time, but I do think at some point, if it's not today, it needs to probably be next month. We need to really look at the cost projections and the rate development sections of this appendix and make sure that they are in line with what the board's desires are. So if you recall from public comment, we talked about the commingling. I think originally the idea was that the plans, well, let's put it this way, well, there was two plans. So there was a fully insured plans, the HMOs. When we first did this, there were the fully insured plans, the HMOs, and the self-insured high deductible plans. There were only two plans when this document was created. So the commingling between the low deductible and high deductible wasn't an issue because there wasn't a low deductible plan. So the high deductible plan stood on its own. The HMO plan stood on their own. Then over time, the HMO in the north became too expensive. They moved that to the EPO. Then they added in the third plan, the low deductible plan. So now we have to decide, are the plans going to stand alone? So the commingling for between the participants in the low deductible and the high deductible plan, are we going to commingle that, or are we going to set them separate? And so and then the other piece of it is that there is a flat subsidization. So I think you're kind of seeing a little bit of, you're commingling all the pools together, then you're using the same, subsidization model for both the low deductible and high deductible plans. Is that creating really a dual, a subsidization of the low deductible plan by the high deductible plan? Are the high deductible plan paying more than they should? The low deductible plan paying less than they should? And then you've got the EPO/HMO that are out there that are fully insured. We get premiums, and so I think the idea is we're going to have to look at these sections and how we want to determine the rates and subsidize the plans by plan and by tier. So that is a discussion we can have today, or we can have next month if the board members want a little bit more time to think about that. But I'd be interested in comments, concerns from the board members on that piece.
Lane Harper for the record. In the existing rate comparison documents that are presented to PEB members, there's a breakdown of the unsubsidized rate, the base subsidy, which is flat across plans, and then each plan premium. And the intuition might be that if you subtract the base subsidy from the unsubsidized rate, that the remainder would be the plan premium. But there are differences in those numbers, and it would be helpful to have more background on what that asterisk and the mention of reserves on the slide represents.
Yeah, that's great. Fair point. And I think we'll talk about that more in the agenda item where the actuaries are going to present the plans. Any other comments on this set? So I'm taking, we're going to wait till November to finalize it. Okay. Same thing, the subsidy allocation, that was the one I was talking about, the single subsidization strategy. Originally in this document, there was a tiered subsidization strategy as opposed to a single flat tier. So it was the intent of the original intent when we did this document was for the plans to be relatively equal out of pocket. So you can pay a higher premium and you pay lower costs when you utilize services, or you pay a lower premium and you pay higher costs when you utilize services. But your rough out of pocket costs were supposed to be relatively equal from one plan to the next. So it wasn't necessarily that we were subsidizing plans, it was allowing individual members to pick the plan methodology that worked best for them. And so that's one of the things that we'll want to think about as we do this, is that, you know, we want the plans to be relatively equal. It's just how you pay for your insurance. On page 5, the underwriting, I'll be honest, I struggled with the underwriting, the new language that was added for the underwriting. I don't know if anybody else did, but one risk pool and 2 risk pools, it just, there's just confusion for me. So I'm not sure exactly what was intended under this underwriting, but it was more confusion to me than it was clarity. So I don't know if you want to explain what you were trying to put here.
Leslie Biddleston for the record. This underwriting section was written by our previous chief financial officer. And it was included in this because I had that language from her. I don't know where it came from. That's kind of why I premised that we do need a CFO to look at this, to especially Appendix A, to make sure that that's all up to date. But I cannot answer where the language came from. Just who put it in there was the previous chief financial officer.
Okay, I'm gonna suggest, at least for now, that we remove that
Okay.
section. I don't, for me, it did not add any clarity, it just added confusion. Any other questions, comments on the board's policies and procedures? Okay, I'll ask that the board kind of look at the Appendix A specifically as we get ready to for the November meeting. We'll look at that. I do want to update this for this board's so that it reflects the board's desires for this particular sections. Anything else on agenda item 6? 6.3 is a discussion on identifying a meeting to discuss the strategic plan. Any preferences? So we have two, I guess there's two different models we could do. So the health authority is working on a strategic plan now, correct?
Mhm.
So we could wait until the strategic plan is adopted by the health authority so that we can then align the strategic plan for PEB into what the health authority has. Or we can update our own now and then revisit it once the health authority's plan is complete. Preference?
Kick it on for
Never
the record.
again.
Thanks. I think I'm leaning a little bit more towards waiting on the health authority to develop their strategic plan, because I think that's going to pretty heavily influence how, you know, what we do here now that we are under their purview. But that's just my personal opinion.
Does anybody know when it was strategic plan was last updated?
Teresa Carson, oh, did you look? I think the last time I looked, the version that I pulled was from 2018. That was online, yeah, 2018.
Okay, well, since it's 6 years old.
Okay, okay, good argument for the record. It's I'll revise my statement. What if we started by reviewing it, maybe calling out some pieces that might be of concern, and then we, you know, anything that might be an easy lift to finalize, we finalize, but we'll need to bring it back as an item after the health authority does theirs. Okay, yeah, I would.
Yeah, let's put this on, I don't know about, we'll see how full November's agenda is. If not, we'll put it on January, but I think 18 is is too far, is too long for that to be, sitting. Okay, so it'll either be on November if the board meeting is not too full, or it'll be on the January board. Anything else for agenda item 6? Hearing none, we will close agenda item number 6 and open agenda item number 7. Discussion and possible action on recommending.
Chair Wells, this is
Yes.
Radhika Kunal for the record. I just want to, just for the clarity of the record, I just want to ask if the prior agenda item was closed as tabled for the future agenda meeting, or was that a motion to determine which agenda meeting it's been tabled to?
No, I think we're just gonna, I'll just put it on the agenda. I feel as it fits best.
Okay, so you're going to table it for the future agendas?
Chris Fatone, is the question about 6.1, the amendments that do we want to approve those?
Well, I guess we could do that. We could approve the amendments that are in the document. So we'll reopen agenda item number 6. We'll take a motion to adopt the changes that we have gone through this document today, and we'll bring back Appendix A to the November board meeting. So can I get a motion?
Kick it
Yeah,
on.
Good.
Take it, I can so moved, or second.
Do I have a second?
I'll second
Jim Barnes, I second.
I think Joy beat you this
Like,
time.
I feel like we need flags or lights or something.
We have a motion and a second. All those in favor of adopting today's changes and bringing back Appendix B to the November meeting, say aye.
Aye.
Any opposed, no. Motion carries. Now we will close agenda item number 6 and move to agenda item number 7. Discussion and possible action on recommended changes and updates to the master plan documents for plan year 2026. Ms. Middleton again.
Thank you, Leslie Biddleston, for the record. Agenda item number 7, there is a document in your packet. And this talks about changes to the master plan documents. And this document is laid out in a way that kind of outlines which changes will be made immediately effective the current plan year and which changes will be made in the future. And I will talk about that as I go through the document. And some changes are clarifications and some changes are enhancements. So I will identify as I go through each one of these. On the first page, clarification to condoms. As some of you recall, we clarified condoms in a previous master plan document change. However, we did not clarify how condoms would be paid for or reimbursed. So we have added some language to the master plan documents for that. There are 2 ways that condoms may be paid for or reimbursed. So this clarifying language will identify how that works. For a pharmacist to submit a medical claim for condoms on a member's behalf, a member must have a valid prescription. For condoms purchased over the counter, a receipt for reimbursement may be submitted to UMR, our third-party administrator. Please see how to file a claim in the claims administration section. So that is a clarification for current plan year. Moving on to the second one, this is also a clarification per request by our third-party administrator, UMR. Just clarifying circumcision. Circumcision for infants 8 weeks and older requires a prior authorization. Moving on to the next clarification. This is also under prior authorization. In the MPDs, the prior authorization did state for hospice, prior authorization was required at 185 days or greater. This was also a UMR staff recommendation to change that to 6 months. So the new language will be change prior authorization, or the change prior authorization from 185 days to beginning at 6 months. So those three clarifications that I just talked about will be for current plan year. Moving on to section 2, this is also a clarification, but to claims processing. And this is as a result of AB 52 from the 2025 legislative session. After this document was posted, we decided to change the language again. So what is there will all be removed, and the new language, I'm going to read it right now for the record. Within 30 days of receipt of a clean claim, PEB members will be notified if the claim is approved or denied. The claim cannot be adjudicated until completed correctly with all required documentation submitted for review. So per Assembly Bill 52, this must be updated and go into MPDs effective January 1st of 2026. So this is a future upcoming for January 1st. Section 3, the following enhancement, this is an enhancement which will be effective July 1st, 2026. This is pursuant to SB 344, 2025 for genetics counseling and screening. The black language that is there for those of you who have color is current language. We are adding a paragraph, and you'll have to go to the next page. The new paragraph reads, the plan covers non-invasive prenatal screening, that is drawing blood from a pregnant person to perform laboratory analysis on the DNA circulating in the maternal bloodstream for the purpose of detecting chromosomal abnormalities in the fetus at any time during pregnancy. Prior authorization is not required for such non-invasive prenatal screening. And then we also removed a section, a couple paragraphs down, non-invasive prenatal testing. So we want to clarify that it is a screening. As stated, this will go into the MPDs effective July 1st of 2026, so with the next plan year. Under number 4, this is also an enhancement, fertility and family planning. This is a result of AB 428 from the 2025 legislative session. This is mostly new language. So the plan covers procedures and services for the preservation of fertility that are medically necessary to preserve fertility because the insured has been diagnosed with breast or ovarian cancer, and A, the cancer may, in a healthcare provider's judgment, directly or indirectly cause infertility, or 2, I think that is a typo, that should be B. B, the insured is expected to receive medical treatment for the cancer, and such treatment may directly or indirectly cause infertility. A medical treatment may directly or indirectly cause infertility if the treatment has a potential side effect of impaired fertility as established by the American Society of Clinical Oncology or the American Society for Reproductive Medicine or their successor organizations. These procedures and services covered under this provision are those that are consistent with established medical practice or any guidelines published by the ASCO or the ASRM or their successor organizations. Other than procedures for the preservation of fertility for insureds diagnosed with breast or ovarian cancer as set forth above only, and then the black is existing language, so to the end there, starting on the next paragraph, new language, other than the procedures and services for the preservation of fertility for insureds diagnosed with breast or ovarian cancer as set forth above, and the rest is existing language. The last paragraph, it is existing language. We added an and removed and sexual dysfunction services. So as stated, this is new language as presented, which will go into the MPDs effective July 1st, 2027, the next plan year. Also, there is a clarification which will accompany this change. In the section, in the benefit limitations and exclusions section related to family, maternity and family planning, the new language will read, except as otherwise specified in the schedule of benefits section. So that's referring back to everything that I just read. So that is an overview of the changes presented, and as stated, some are clarification, which will be for this current plan year, and some are for future plan years. The reason we bring language to board meetings is so we can continue on with our implementation process of new legislation. So this is just a part of our implementation, bringing the new language to the board for approval. And as stated, it will be held until the appropriate time and placed into the MPDs. The recommendation from staff is to approve the staff proposed changes and also the new language that I read in, and allow for any technical adjustments as necessary.
Thank you, Ms. Biddleson. Any questions? Ms. Duncan?
Keiko Duncan for the record. For the enhancement for, with the justification being AB 428 of 2025. And I'm just not familiar with the language of that bill. But was the side effect of impaired fertility as established by the AASCO or the ASRM, are those two bodies defined within the bill? Is that why that's what's been referenced? Okay.
Other questions?
Teresa Kirsten, for the record, for consideration, I would just for item 1, like to suggest and recommend that our language when finalized reference the TPA, which is a contract type, right? Rather than UMR, it was our currently awarded vendor. Thank you.
I had a question on the fiscal note that was associated with Assembly Bill 428. So I'm assuming that there was a fiscal note from PEB on Assembly Bill 428, and that is the reason for the delay.
That is correct.
Do you remember what the fiscal note was?
Not off the top of my head, but the one that you're talking about, the family planning and fertility, the reason that it was pushed back to July 1st of 2027 was so PEB can include whatever the fiscal note was into the budget. And I don't know, Ms. Mooneyhan, do you remember what the fiscal note was? Because I don't off the top of my head.
I don't off the top of my head, but I can find it.
Yeah,
Let's search his website.
And then I have a question for Ms. Kuhnel. So the item is for updates to master plan documents for plan year 26, but we are obviously making adjustments for documents for FYs 27 and 28. Because
Yes,
we're
sir.
adding all of this language into to the current plan document or the document that will be effective next. So really, it's only section 1 that's covered by FY or plan year 26. Number 2 is plan year 27. Number 3 is also plan year 21 and 2. So 2 would also be plan year 26 because it goes into effect in January. 3 is plan year 27 and 4 is plan year 28. So can we make changes to future plan years even though it's not a general?
This is Radhika Kunal for the record. I'm afraid we cannot make changes based on, I'm looking at the agenda item, that's now noticed agenda item, and it is limited to plan year 26. So I'm afraid making changes to the future plan years is not properly agendized and would not comport with the OML requirements. So if the board is inclined to make a vote on this agenda item, maybe limit to the items that comport with the agenda item. unless I'm missing something. Yeah.
Thank you. The fiscal note from the agency that was submitted said that the annual cost would be about $216,000 or $495,000 in future biennia. It mandates additional coverage for procedures not currently covered under the PEB plan. So that's the estimated cost by PEB for this, for number 4A, I guess. So we will not be able to take action on numbers 3 and 4. We'll need to bring them back to a future meeting. Are there any other questions on the items 1 and 2? If not, I'll accept a motion to amend the master plan document for plan year 26 for section 1 and 2 of the attached document.
Janelle, would
Motion, do I have a second?
Jim Barnes, second.
I have a motion and a second. All those in favor, say aye.
Aye.
Any opposed, no. Motion carries. We'll close agenda item number 7 and move to agenda item number 8, presentation and possible action on the structure and financial results of the current value of. Mr. Ward.
Morning, everybody. For the record, I'm Richard Ward. I lead the Siegel team of consultants and actuaries that work at PEB. Part of a large team. A number of us made a significant amount of contributions to all the work that we do for PEB and for the board. Joined here at the table by Nettie Riazzi, who's our OPEB or retiree health actuary. And then also here in the room today, Amy Cohen, who's an actuary on the team, and then Shelley Chung, who's a pharmacist. And we've prepared some materials to discuss today. So under agenda item 8, just to get everybody oriented here, our materials start on page 71 of the packet. And there's been, and on page 72, just a review of the agenda. We're gonna review benefits, premiums, and enrollment through fiscal year 25 for some recent plan years, as well as showing a projection for the next biennium, the rest of this biennium and the next biennium. We'll discuss some reserve levels. We'll look at some high-level trends and cost drivers. We'll talk about the most recent retiree health valuation, OPEB, and then there's a section on prospective plan changes for plan year 27. First, just to orient us here and ground us, is a summary of the benefits for the 4 main plans, the CDHP, the low deductible PPO, the EPO, and the HMO, which are rated together or blended together for when setting rates and premiums. And across the top, we have the actuarial value for the plans, and the actuarial value is a figure that represents the portion of total costs of care that are paid by the plan on average. And so for the CDHP, it's 76%. And what that means that for every $1,000 of incurred costs, 240 would be paid by the patient on average, and 760 would be paid by the plan. So it's a way to represent the value of the benefits of the combined value of the deductible, the co-pays, the max out-of-pockets, and all the cost share. And the higher the number, the more generous the coverage. And so there's The CDH plan is at 76%. The low deductible plan, a low deductible PPO is about 9 points more generous. So about 9% at 85%. And then you can see the EPO and the HMO are a little bit higher still. And then on the bottom row, just for reference, we have the employee-only premium for the current plan year, for plan year 26. So the monthly premium. So to enroll in the CDHP, an active employee would pay $55.26 a month. And then you can see the higher amounts for the other plans. And I'm going to come back to this a couple of times, but I want to note the spread between the actuarial value and the premiums, in that there's a significant spread between the PPO and the EPO HMO option in the premiums. You can see on the bottom row there. And on the top row, especially between the low deductible PPO and the EPO, there's only a 3-point difference in the actuarial value. So there's a bigger spread is how I would characterize it in the premiums than in the benefit value. So we've had some discussion today already about rating policy and the methodology that should be utilized. And we've reviewed some language that I think you will review in November about how to establish the rates for the different plans. And there's some different ways to do it, which we've discussed a little bit. One way is to rate each plan option on its own and then apply a subsidy that then nets out what the employees would pay the balance. And then another way is to blend the experience in some manner between the different plan options. To start off, though, for fiscal year 25, and I'm on page 74 of the board packet, we just took a look at how the different plans have compared, or how the comparison is between the revenue in fiscal year 25 and the total expenses, and then how does that net out? And it's been noted earlier today that the CDHP there's more revenue than expenses, and then for the other plans, it's the opposite. There's more expenses than there is revenue. And so the one way to characterize it is that the CDHP plan is subsidizing the other two plans. And that's not an uncommon thing in self-insured plans that have multiple options. Generally, there's a focus on the overall health and performance and stability of the program in total. And so a tool to manage those things is sharing risk between different plan options, which is, I think, at its core, sort of what insurance is. And then I'm sharing my risk with other people in the pool. And so that is with other state plans that we work with that have multiple options, that's not an uncommon thing. I will note there in the bottom right that there has been a spend down in assets during fiscal year 25. So the PEB paid out more in benefits and admin expenses than came in revenue from state contributions or employee premiums or pharmacy rebates, or the other main revenue streams. You can also see the relative enrollment here. The CDHP has the most enrollment at 14,000 contracts, subscribers, families. The low deductible PPO is not far behind at 12,000. So that's the second most popular choice. And we'll see how those enrollments have changed over the last couple of years. And then the EPO and the HMO, both options have seen declining enrollment over the last couple of years. And that's in total between the two at about 6,300. Okay, moving on to the next slide. This shows the participant-only tier, so the single tier for employees. This illustrates what we were seeing on the prior page, where we have more revenue allocated to the CDHP plan than we have expenses, and then the opposite for the other two plans. So these are the published rates from fiscal year 25. So I believe, we checked it a couple of times, but so I hopefully the top rate here is what is characterized in the open enrollment guide as the unsubsidized rate. So it's the total cost. And so for the CDHP plan, employees looking at single coverage would see $714.88 for plan year 25, see a base subsidy of $651.32. The board made the decision to offset some premium increases for plan year 25. And that's what that third line is. That's a plan spend down of plan reserves. It's $8.30 for the CDHP plan, and that nets out to the $55.26 that employees pay for the CDHP plan. And that includes, that considers, that top line considers, well, let me just say it a different way. The 714 and the 753 and the 852 do not represent the projected or expected expenses for each of those plans in isolation. Those are rates that were used for rating purposes. So I think we've had some discussion that over time, there's been some difference in the stated policy versus the practice. This practice goes back several years. It was in place in some fashion when we started working with PEB a few years ago. And I think the focus has been on the total health and performance of the program. So as we're beginning the review and the discussion of what to do going forward, we're showing here what would happen if we just let the math flow. So if we had rated the plans separately and then applied the flat dollar subsidy across each plan, that's the 651, and that's the second half of the table. So see that the total cost for single coverage for the CDHP plan would be about $100 less than what was used to determine the employee premiums. You can see that it'd be about almost $50 higher for the low deductible PPO, and then significantly higher for the EPO. And then we apply the same base subsidy of 651 and then the same plan spend down, and then we just let the math flow. You can see some significantly different premiums would be the result of that calculation. Now, I do want to note that if this was the approach that was taken and this was the result of that first calculation, we would then look at and consider how enrollments would shift. Because if you did this, people would leave the EPO and the HMO for the lower cost plans, and I doubt you do a negative premium. We're showing it here just to illustrate how the magnitude of the subsidies between the plans and how the employee premiums could be different with a different approach. And when we would consider the migration, and selection is a term that we use. So the lower cost people in the EPO would leave the EPO for the lower cost plans. And then that would leave the higher cost people in the EPO. And the cost of the EPO would be even higher once we considered that migration. And then depending on how it looks, how the people that leave the EPO compare against the other plans, the rates for those plans might also go up as well. So this is really just this would be the first in a iterative process, or the first calculation in an iterative process, because we would model some migration assumptions. We'd see what those results would look like, take a step back and consider what employees might do when presented with that revised premium schedule and the benefits that you would get by those choices. And then maybe we would reassess the migration and selection again. And so it's an iterative process until we feel like the dust has settled. Okay, the next slide just shows how the subsidy would be different if, again, we still let the math flow, but then the CDHP plan doesn't have a negative premium. A negative premium would mean you're paying people to go into the CDHP plan. And that doesn't seem like a realistic scenario. So we're not the policymakers, of course, but that if you zeroed it out, then the subsidy would be $43 less. That's the difference between the 651 on the prior slide and the 607. And again, there'd be significant migration even with this scenario. So this is just, we're looking at how things could have looked in fiscal year 25 with the people that were in the plans during the year. When we were looking at the plan design earlier, I mentioned that there's a large spread in the premiums between the plans and a smaller spread in the plan value or the actuarial value. And in particular, between the EPO and the low deductible PPO, or the EPO HMO and the low deductible PPO, the spread in benefit design is a lot smaller than the spread in the premiums. And that is driving an ongoing migration out of the EPO and the HMO. And then also, I think here, the CDHP, by nature of the subsidy to the other plans and the magnitude of that subsidy, is leading to people that are in the CDHP reassessing the value that the plan provides for the premium that they have to pay to get into it. And we're also seeing migration from the CDHP plan to the low deductible PPO. Okay. On the next slide, just graphically showing the premiums for the employee only tier. I think just a graphic representation helps digest the difference. The EPO is the one on the right in the purple, and it's significantly higher than the other plans. It's about 4 times the CDHP premium, and the low deductible plan is about 2.5 times the EPO is about 2.5 times the low deductible PPO, and you can see how that's changed over the last several years. Okay, on the next slide, we have a graph summarizing migration for the different plans over the last several years. The top line is the CDHP, and back in 2021, you can see with 23,000 people compared to about 7,000 for the other plans, it had the lion's share of the enrollment. The low deductible PPO was introduced and maybe had modest initial enrollment, and that has grown steadily over the last several years. And you can see a corresponding reduction in the CDHP plan, and then the EPO and the HMO are shown as the lower 2 lines, and there's a modest reduction in those plans enrollments as well. And I think this is driven by the difference in the benefit design and the relative difference in the premiums. And people are identifying the low deductible PPO as the best value for them, and they're changing plans during open enrollment. Okay, now on the next slide, we've got some trend graphs or some cost graphs. The top right graph represents trends in the industry. So they're not PEB trends, but just general industry trends for group health plans similar to PEB. So we have a medical trend in the light blue line at most recently 7% and 7.5%, and those are year over year plan per capita costs. And we have pharmacy trend in the darker line at the top that's 12, 12, and 10.8%. And the source for these is an annual survey that we do, that Siegel does, where we solicit assumptions and experience from all the carriers in the country, administrators, PBMs, so United and UMR contribute, Express Scripts contributes. And so we synthesize all of that information so that it's representative of the industry. They're not our assumptions. It's what the industry as on an aggregate basis is indicating is being assumed, or for prior years has been what the experience is. And this can be a helpful benchmark to understand when we're having periods of high trend for PEB. Is that happening nationally? Or is there something specific to PEB that's happening that's different than what we're seeing nationally? The bottom graphs show per capita costs for PEB, medical on the left, pharmacy on the right. And these are PMPM trends, so it's on a per capita basis. And the last 2 years for medical, PEB has 4.8% trend and 7.0% trend. And comparing that to the industry, it's about at industry levels, or maybe even a little bit below for the prior year. But you can see that there's an ongoing steady march of increasing costs. For pharmacy, we see higher trends. We see 20% in claims costs for 1 year, and then not quite 10% for the subsequent year. The two lines here represent, the top line is just claims cost, and then the bottom line is net of rebates. So for a lot of the more expensive prescription drugs, for specialty medications, the manufacturers provide a rebate that Express Scripts collects and passes back to PEB, and that offsets the claims costs. And so we think it's helpful to look at claims costs, but then also net of rebates, because that's really maybe more reflective of the true costs of pharmacy. And I mean, generally, we see about a 35 to 40% offset in the claims costs once we consider rebates. Some of the trend drivers for PEB in general for pharmacy, even though PEB doesn't cover brand weight loss medication, we've heard a lot in the news about GLP-1 medications and all the different applications that all the applications and ways, things that they can how they can help patients. Weight loss is one of those indicators. PEB does not cover weight loss for GLP-1s, but you do have GLP-1 utilization because they're often prescribed for diabetics, right? And so you're still seeing significant trend increases in utilization for Mounjaro and Ozempic, which are two of the leading GLP-1 drugs. And that trend and those costs are increasing at significant rates. We're also seeing specialty patients, a number of specialty patients, and the costs increasing by strong double digits from fiscal year 24 into 25. And then for medical, there's a number of high cost claimants. In the last couple of years, there's been new life-saving treatments that weren't previously available, but they are expensive. And there are medications that are available and gene therapies that are coming into use that are very helpful and improve patients' health in ways that weren't possible even a few years ago, but they're all very expensive. And then we have increasing prevalence for cancer, diabetes, and musculoskeletal utilization of the percentages that we see there. And those are just an ongoing group-wide health needs that PEP members have, which are not unusual for a group health plan. So like the takeaway here is that we should continue to expect trends of 7 to 10% annually for the next year or two. That's what we're seeing nationally. Okay, now we're going to look at two things that were driven by changes from the Affordable Care Act. Prior to the Affordable Care Act, PEB had a $2 million lifetime maximum benefit. So a dependent member patient in PEB, when there'd be $2 million in plan costs incurred over the lifetime, that was the end of coverage. Affordable Care Act comes along and eliminates lifetime maximums, prohibits lifetime maximums. And so over the last several years, I'm sorry, I'm on the wrong slide. Let me just keep going if it's all right with the lifetime maximum benefit, and then I'll go back a slide. I apologize. So we looked at PEB data over the last 7 years, and there are 24 members that have exceeded the $2 million lifetime maximum, and they total $84 million in costs, with 36 of that in excess of $2 million. Most of those high-cost claimants and those patients, their situation is episodic. So we look at, when we have high-cost claimants, we look at episodic and chronic are the two main terms that we use. And chronic means somebody may have a rare blood disorder and they require ongoing treatment, so we expect their care to continue going forward. Episodic, you can think about it more like a skiing or a car accident, and that is a high-cost situation, or maybe they have cancer and the cancer is in remission. They're not expected to continue. And most of these high-cost claimants are episodic. There are 15 of the 24 that are still currently covered in PEB, and there's another 15 that are between 1.5 and 2 million that may very well cross that 2 million mark. And I think one way to look at this is if we have 36 million in that over 2 million, 36 million in expenses over that previous lifetime maximum of 2 billion over 7 years, just a straight line allocation, and that could be about 5 million a year in costs. And now I'll go back to the other slide. Apologies for skipping over it. Another change driven by the Affordable Care Act is the requirement to cover all dependent children to age 26. PEB previously covered to age 21, and so there's a whole new age group that PEB has covered since then. And while those dependents are generally lower cost, I think if your typical 22, 23-year-old young adult is going to be healthier than a 50-year-old state employee covered on the plan. But nonetheless, it's additional cost to the plan, and the funding to PEB is on a per capita basis. So we'll talk about AGIS here, which is the monthly per capita funding that comes from the state. That doesn't change by adding more dependents. And there's some modest offset by people maybe are single coverage and then they add a kid and they move up a coverage tier and pay a slightly higher premium. But generally, these are added costs for these additional dependents, even if they're relatively low on a per capita basis. Looking back at plan year 25, the age 21 to 25 dependents, it's about 17.5% of all dependents are in that age band. And 25% are in that age band, and the costs associated with them are 17.5% of the total cost. So they are a little lower cost on average, but it's still 11.5 6.4 million in expenses for the age 21 to 25. Okay, now let's move forward to reserves and projections. So we've got a line graph here. The top two lines, just to orient us here, red is expenses. Blue is revenue for those of us looking at it in color, and if you're looking at it in black and white, the line that's generally higher of the two is expenses. And then down at the bottom, there's a black line, which is a reserve target for IBNR and catastrophic reserves. And then the green line, excuse me, represents assets. And if you don't have color, the flatter of the two, that is generally just above 100 million, is the funding target. And these figures are in millions. I think a takeaway here is that prior to fiscal year 24, for several years, there was a concerted effort by PEB to reduce the overall assets. Assets were above the funding target. They were above catastrophic reserves, and the term that is used for those is excess reserves, which I think my personal comment here is that can contribute to the thought that since they're characterized as excess, is that you don't need them. So you're trying to spend them, and as a result of spending these excess reserves, the effort has been to get down to the funding target, which is really hard to maintain on a consistent basis. So the margin was spent down, and that coincided with a time when expenses trended up, and so the spend down overshot that target. And as has been pointed out previously, in plan year 25, there was a spend down to a level below the target funding level. So the target funding level, 102 million versus 67 in assets. Let me just talk a minute about the reserves here. So the IBNR reserve, or the liability, IBNR stands for incurred but not reported. And it's a representation of the liability that the plan has at any given time for claims and care that have been provided but haven't been paid by the plan yet. So I think a way to think about it is these are measured on June 30th. So someone goes to the doctor on June 29th, and there's a claim submitted, UMR is processing it, but the money to pay that claim is still in the trust. It hasn't worked its way through the process yet. So this is happening on a daily basis where there's care being provided, claims are being submitted, they're being processed, and there's some time, it takes some time to work through that process before it's invoiced and paid, invoiced to PEB and paid out of the trust. The IBNR at any given time is somewhere between 44 and 50 million. And then we've talked about the catastrophic reserve calculation, which is 45 days of claims. So we take the annual claims, divide by 365.25, multiply it by 45. And that's the target for that catastrophic or that solvency component of the reserve. The graph here for the future years, for plan year 26 and forward, assumes no changes in employee premiums, no changes in benefits, no changes beyond plan year 2027 for the Aegis and the Reggie. And while we would expect something will happen, benefits will be changed in the next biennium, 28 and 29, there'll be a change in state funding, employee premiums might be different. This can be a helpful view to see that something should happen. Otherwise, there's going to be a dramatic spend down. In plan year 2026, we're expecting a slight rebuild in assets. I'm going to draw your attention to the chart in the top right where we're showing the AGIS and the REGI. AGIS is state per capita funding for active employees. REGI is a monthly per capita representation for retirees. And between the biennium that just ended in fiscal year 25 and the next biennium, there was a significant increase in both. 759 to 1022 in the AGIS from 25 to 26. And so that increase has covered costs for plan year 26, but they actually decline a little bit for plan year 27, which is concerning as we're looking at plan year 27. I invite questions if there are any. Otherwise, you're going to hear another actuary talk here for a little bit longer. Okay. We also, in the packet, there's a report, our IBNR report, which has detail about the IBNR and the catastrophic reserves. We also have our OPEB report, retiree health reports. But we have a couple of slides here just to talk about the retiree health valuation, the costs and the liability associated with it, and some of the accounting requirements that y'all have to comply with under GASB for disclosure purposes. And I'll let Dave take the lead on that.
All right, board members, good morning. For the record, my name is Mehdi Riazi. I lead the team at Siegel that prepares the retiree healthcare valuation. The formal name is the GASB 7475 OPEB valuation. And as Richard mentioned, before we show the numbers, it's a liability of about 1.4 billion that we calculate. I thought we'd spend a few minutes talking about the background, why we prepare this report, what it's trying to accomplish, and a little bit about how we developed this $1.4 billion liability estimate. So this first slide is on page 83 of the packet. The most important thing to remember about this report is that it's just an accounting requirement. There is no requirement to set up a trust and try to pre-fund this $1.4 billion liability in a manner like the state's pension plans are operated. Right? In fact, most plans, retiree healthcare plans, operate on a pay-as-you-go basis. That's how they're funded, similar to PEB. This acronym OPEB stands for Other Post-Employment Benefits. Other means other than pension. And so the goal of the report is to try to measure what type of retiree benefits, what are the costs for the retiree benefits other than pensions that have in some sense already been accrued. So that's what we're trying to measure, is based off of the service that's been provided, what kind of future benefits are related to the service that's already been provided. That's the fundamental idea from an accounting perspective. This all started about 20 years ago when this type of accounting and these disclosures started. And GASB, the credit rating agencies were in their ear, and they were telling GASB, we want to see more about the long-term costs. And that was a lot of the reason why GASB, instituted this requirement, was really to get employers thinking about the long-term costs for retiree healthcare benefits and are they sustainable? And at the time, once these liabilities got reported, it started appearing on the plans disclosures, and the participating employers, they have to report a certain portion of this overall liability on their financial reports as well. Many plans started making changes, and that happened at PEB as well. So at the bottom of this slide, you can see the benefits for retirees, and there's a huge line based off your date of hire. If an employee is hired before January 1, 2012, then they can keep their active healthcare plans before Medicare age. and they receive premium subsidies that are based off service. Once they get to Medicare, there's a contribution to their HRA they can use on a Medicare exchange. But the employees hired after 2012, January 1, 2012, much different story. No contribution to an HRA once you get to Medicare. And for the early retirees, they can participate in the plan, but they do not receive any premium subsidy. So they would have to pay the entire premium. So drastically different benefits depending on your date of hire. And that's really the story of this valuation. So when credit rating agencies or whoever starts looking at this report, that's really the story that comes to light. Now, that last bullet point on this page, it says that all non-Medicare retirees benefit from the implicit subsidy. I wanted to mention that because that's an important feature of this report, that even the employees that were hired after 2011, technically, for the purpose of this report, they do receive a benefit. It's a very small benefit because they have to pay the entire premium. But the way the accounting community looks at this and the actuarial community looks at it is there's a cost to the plan though, because retiree claims are higher than that blended premium, right? PEB's membership is active employees and early retirees. And so those premiums for the self-insured plans are based off of the active employees and early retirees. So it's what's referred to as a blended rate. And so by having access to blended rates, GASB argues that there is a benefit, that difference between the claims they generate and the premium they pay, that's a real cost. So that's referred to as the implicit subsidy. And that's important to keep in mind because I think you often hear there's no benefit for employees hired after 2011. And when in reality, that maybe feels like the case, technically there is. On the next slide, I want to just mention a few words on how we calculate the main liability measure in this report that's referred to as the total OPEB liability. Its technical definition is the present value of future benefits attributable to past service. And so that definition's got three pieces. You have a present value. So this $1.4 billion number, it's a single number, but it's related to all these future benefits. All these future benefits get discounted to today using some interest rate or discount rate since you're going backwards to get a single number that if you did earn somewhere around 4%, that you had 1.4 billion in an account that could earn 4%, that would be enough then to cover the future accrued benefits and with the earnings it would get. And then also to estimate the future benefits, if you read through our report, half of it is just the assumptions we use. So this number is heavily dependent on assumptions. We have to, for the active employees, we have to predict, some of them terminate before they even get to retirement. They retire at different ages. They live some kind of assumption about mortality. What percent take the benefit when they get there? For the employees hired before 2012, based off of the data, the plan's experience, we have an assumption of 85%. So for that group, 85% participate. For the post-2011 employees, our assumption is 35%. So, which makes sense given the difference in benefit payments. We use the same assumptions that PERS uses as far as termination, retirement, mortality, and then we have to develop a healthcare trend assumption. We're starting at around 8% this year, and participation assumptions that I just discussed. We have to layer on a few more assumptions, but that's how we develop all these estimates of future years. We literally are trying to estimate every future year what the costs are going to be, and then we discount it to today. And then that last piece at the bottom is this is an accrued liability. So we look at what portion of these future costs are based off past service or in some sense kind of already earned. What costs have already been earned is really the gist of this number. Right, and on the last slide, just to look at the actual numbers, you have the June 30, 2023 results on the right, the 24 results in the middle, the annual benefit payments for the year that ended June 30, 2024 were about $68 million. So the way you get that numbers, you look at how much claims did the retirees generate, you net out what they paid in premiums, and then you also have the HRA contributions and such. You add all that together, $68 million. Right, now the total OPEB liability is $1.3 billion, which is about 20 times as big. And I think that when you hear that, it hopefully puts it into perspective, right? We're trying to measure these long-term costs, so this number is about 20 years of last year's costs. Just kind of help understand why it's so darn big. The number by itself is hard to put in perspective. And so when the credit rating agencies look at these disclosures, one of the key metrics they look at is what's that liability as a ratio of payroll, right? Because everyone's kind of different size. Some employers are bigger than others. But when you divide by payroll, you can sort of normalize. You can start comparing people. So at PEB, that ratio, June 30, 2024, was about 53%, right? Which is pretty middle of the road. Right? Some of those ratios are really low in the teens. Some of those ratios are up like 200%. So 53% from a financial angle shows that the benefit is being managed well from a financial perspective. And then when you dig in, you see, well, that it looks middle of the road overall, but in reality, there's really two groups, right? There's this really valuable benefit. And then there's the post-2012, post-2011 group, pardon me. The liability really was pretty similar from the prior valuation. It's a little bit lower this last measurement. The claims came in a little less than expected. We did lower the participation assumption slightly, and the discount rate, because the plan doesn't have formal assets, isn't pre-funded, the discount rate is tied to market municipal bond rates. And those fluctuate, and this number fluctuates as well with that volatility. And so that, as interest rates are on the rise recently, have been on the rise recently, and so that actually brings this number down as these future benefits are discounted more. But overall, pretty similar results, pretty similar story as the past valuation. And to wrap it up, at the bottom of this slide, I want to talk about those employees hired after January 1, 2012 that don't receive explicit premium support. That's about 71% of the current active employees fall in that post-2011 group. So most of the active employees would have to pay the full premium for coverage, about 22,000 out of the 31,000 active employees. There was a bill earlier this year that we analyzed about reestablishing the subsidy for the post-2011 hires. In that analysis, we noted that the accrued liability would increase by about 12% or $200 million. One of the things that we didn't note is the impact on the total present value benefits. So the total present value benefits, you're basically ignoring the accrued piece. You're just saying what's the total projected costs for everyone in the plan. We're not showing that number on this page, but it is in our report, and it is in the disclosures for bond offerings. It's one of the numbers that the state puts in those disclosures for the bond offerings. That's $1.7 billion. That number would go up by 40%, or about $700 billion, if those benefits were reinstated. So there was a big change, for those employees back, 13 years ago. At the time, it may not have looked as big because their service was so low. But now, as their service is higher, the impact would be larger to reinstate those benefits. So with that, conclude our prepared comments. Happy to answer any questions about the OPEB evaluation.
Any questions on the report so far? Hearing none. Continue on to the approved plan changes.
Okay, then Richard Ward for the record. The next section, next several slides are about plan changes, and to level set here, we have a slide on changes that were approved at the July board meeting, some of which we discussed here a few minutes ago, but I think just a helpful reminder that there are already some modifications that have been approved for the next plan year. So covering wigs for alopecia, we think that's a negligible financial impact to the whole plan. It's impactful, of course, to people that would benefit from it. The statutory requirement to increase the eligibility age for speech therapy from 19 to 21, and also expand the coverage, the applicable services or conditions and benefits for that. We estimate that in total is about $50,000 per year. the federal government every year changes the requirements for minimum deductible levels for HSA qualified plans, which is the CDHP plan. And the CDHP plan has historically had the minimum allowed deductible. So every year that the feds change the minimum, then PEB follows suit, and that was approved in July to go from $1,650 for single coverage to $1,700. We think that's about a $500,000 savings based off of current enrollments and utilization. There's a modification or clarification for mental health therapy as well as for autism, and those were discussed back in July. So now I have a couple of slides on some potential changes for the board to consider, and hopefully I'm not speaking out of turn, but I believe the context here is we're going to discuss some concepts, some ideas, and then you'll provide direction on what staff and we will analyze further for the next board meeting and come back with some more specific proposals and fiscal and member impact. These next couple of slides are an amalgamation of ideas from a number of different sources. Some are from PEB staff, some are from board members, some are from other vendors, UMR and ESI. Some are ideas that we suggested. And so we've put all these together, and so we're representing several voices here as we're reviewing these. Okay, so the first one is a medical pharmacy coupon program that UMR has. It works in an analogous manner to the Save on SP program that Express Scripts has. So it takes advantage of drug manufacturer coupons and uses those coupons to offset plan and member costs. There's an administrative component to it. Members need to enroll in the drug manufacturer's program to be eligible to generate the coupon. But the mechanism here is that much like the Express Scripts program for outpatient pharmacy, for inpatient pharmacy that runs through the medical portion of PEB, UMR has a program to take advantage of those coupons to reduce costs for both members and the plan. And this was reviewed 2 years ago, I believe it was, and the board decided not to pursue it because at the time, UMR was not able to apply it to the CDHP plan, only the other two plans, the other two self-insured plans. And the board decided that it'd be preferred to have it applicable to the entire program. And UMR is indicating that, I believe still as of January 1st of 26, that they'll have worked out the administrative and operational considerations so that it can apply to all three plans. So I think the idea here is this conceptually something that the board would be interested in? And if so, then we'll come back at the next board meeting with an impact analysis, number of people, the medications that to be eligible to generate coupons, as well as expected savings for both members and the plan. Okay, the next one, which is on page 88 of the board packet, there's really two items here that we've labeled under care access. So the first one is prior authorizations. Currently, prior authorizations are required before a biopsy can be performed. So biopsy being a diagnostic tool, for want of a better characterization, to further refine the condition and prospective course of treatment. We've seen, UMR has indicated that almost 100% of these prior auths are approved, and there's a cost associated with each prior auth. So the thought is the prior auths are additional administrative burden for providers and for UMR, and are not managing or not serving the purpose that prior auths generally do to ensure that care is appropriate. So they're all being approved and PEB's paying for the prior auths. So the consideration here is eliminate prior auths just for biopsies, not across the board. And then as we wouldn't expect that would impact care, but it likely would generate some, reduce some administrative expenses and administrative burden for providers. The second item here under the what header, the second one is to cover diagnostic breast imaging and colonoscopies at 100%. And currently, if they're preventive, they're covered at 100% because the ACA requires it. But if a provider indicates that an additional colonoscopy or an additional imaging is required, is needed to further diagnose something that the provider thinks may be a treatable condition, then that test and that procedure is covered with cost sharing. It's subject to deductible and co-insurance. And so we're seeing plans, a lot of our state clients have taken a look at this and determined that really that's a barrier to care. And it's desirable for people to have colonoscopies and have breast imaging mammograms when providers think that it's necessary. So remove the cost share that could be a barrier to care so that there's earlier detection, earlier treatment, and a more accurate diagnosis. And while there would be we expect there to be a slight increase in cost for eliminating the cost share in the short term, this could have long-term positive effects. And if this is something you all want to look at further, then we can come back with some more specific and refined analysis on that. One caveat is that because it's technically not preventive, it would still need to be subject to the deductible in the CDHP plan because that's just required by the IRS for HSA qualified plans. Okay, the next one is regarding network lab access and education. So speaking from experience myself, when my physician indicates that I should have some lab work done, it's really tempting and is often the case to just go wherever he or she directs me. And I think a lot of patients don't consider whether that lab is network or not. And sometimes the physician can refer a patient to a non-network lab. And then that can be a bit of a surprise later. So reflecting back on a practice and that PEB had a few years ago, was it a 1-year period as I believe it was as Renown was coming on the network, that PEB would cover the first non-network lab as using network cost share and then provide a letter and education to the member on how to identify and research and find network and non-network labs. So you get a mulligan on the first one, and then some information on and a warning essentially, and then some information on how to research that yourself and identify network providers going forward. So this is to apply this more broadly across the entire program, not just for this one targeted provider that was the case in the past. So next steps would be to determine cost and member impact. Okay, under vision, there are 3 things here. So there's a difference in covered benefits between the 3 plans. The CDHP plan does not cover frames for glasses. So one consideration here is to amend that so that the coverage is uniform across all 3 plans. Two other considerations would be to increase the $100 annual benefit maximum. We see other plans that generally have a higher maximum that provides a more meaningful benefit. That would be a cost increase. And then the plan currently does not use a network of vision providers. So the medical plan and the dental plans use a network of providers that provide services and care at a discount. The vision plan is an indemnity plan and doesn't utilize the same network approach. And this is something that we're seeing plans consider, and that could be a way to offset the cost increase for increasing the annual benefit maximum. So if this is something that you want to look at, we'll come back with some specific options, some benchmarking information to compare the annual benefit maximum with the ABLs for other state plans, and then also review contracting options to access the provider network. So it would need to be researched whether for example, the UMR contract can be used to access the UHC network of providers, and if that's something you even want to do. Okay, for pharmacy, we have two considerations here. The one is changing the copay structure for non-preferred brands. So non-preferred brands generally have an alternative clinically equivalent medication option. So think of it as brand versus generic. And you currently have higher cost share, higher member costs for non-preferred brands, and then lower for generic because you're trying to steer people towards generic utilization. And so I think there's an opportunity to provide some additional steerage towards those lower cost therapies by increasing the brand exposure, the copay. So increase it from $75 to a 30% coinsurance with a minimum and a maximum. So the cost exposure, the cost share for the member would scale by the cost of the drug. So there'd be more of an incentive to consider other therapies for more expensive drugs. And then another consideration is to take advantage of the emerging availability of biosimilars. So biosimilars are specialty medications that are genetically equivalent to specialty medications, but are not the name brand. It's analogous to generic medications compared to brand medications. And previous to biosimilars becoming available in the industry, when someone had a health need that required a specialty medication, that was the only option. They were prescribed this high-cost medication, and there really wasn't a steerage opportunity to incentivize them to consider a lower-cost alternative. Now with biosimilars, we're seeing that there's an emerging opportunity for that. Every year, there's additional biosimilars coming on the market that are providing lower cost alternatives to traditional specialty medications. And so there's a possibility here, we think, of having a separate 3-tier structure for specialty medications that incentivizes biosimilar use when there are biosimilars available. And it's, I think, very similar structure and thinking to generic versus brand. So you have tier 1 for biosimilars that would have the lowest cost share. That'd be like generics. Then you have biosimilars where you have specialty medications in tier 2 where there is no biosimilar currently available, alternative available, and that's analogous to preferred brands. And then for specialty medications where there is a biosimilar available, they're in tier 3 with the highest copay, and that would be analogous to the non-preferred. So if this is something that you wanted to consider, and we'd work to develop some specific proposals and determine the cost and member impact for these specific proposals. And our thinking is this would incentivize more efficient utilization. It would remove costs from the plan. It would have lower costs for members as they're utilizing these lower cost medications. And I don't think you would do this if it didn't result in savings. Okay, next one is income-based premiums. Right now, if you're in the CDHP plan and you have single coverage and you're an active state employee, you pay the same regardless of what your income level is. And there are some states that utilize income-based premiums. So employees that are higher earners, have higher incomes, pay higher premiums than lower income individuals. And there's some different ways to structure that. You can have different tiers between different income levels. So, and then everybody pays the same within that tier. So you could say people that make between 40 and 60,000 pay the same dollar amount, 60 to 80,000 pay a higher dollar amount, but the same within that band, and so on. Another way is to use a percent of pay with minimums and maximums. And if you do that, then you likely have different percentages for single and family coverage. And if this is something that you have interest in exploring, then we could model some different scenarios to see what that looks like. I would suggest doing it initially on a cost neutral basis overall, just so that we can see how much spread there would be between lower income and higher income individuals. Some states that do that New Mexico is implementing this for their next plan year, and then some other states, Pennsylvania and Kansas come to mind, that have done this previously. Okay, and then here on the last slide, it's been considered over the last 2 years to review the ongoing viability of the EPO and the HMO and consider alternatives. This is a very impactful consideration, potentially eliminating a plan option for all employees or for some employees, depending on whether it's the EPO and HMO separately or together. We've seen some significant cost increases in the HMO, has benefited from a rate cap on premium increases to keep the premium below the costs of care. Generally speaking, that only is sustainable for so long. At some point, the premiums will catch up to the costs. Having said that, the HMO is the lower cost of the two options. So people in the EPO are benefiting from blending the EPO and the HMO. The HMO and the EPO have similar networks. I mean, I don't know that I need to read the whole slide here. I think at this point, we want to get some direction on whether this is something the board wants to consider this year. And if so, then we'll do the appropriate analysis to compare do a disruption analysis, compare access between the HMO and the other plans, and look at the cost impact potentially to PEB and to members. And part of that analysis could be to consider benefit changes to the existing plans. Could also include benefit changes to the EPO and the HMO. I mean, just Even if the direction is to continue offering the HMO and the EPO, then there's still the opportunity to consider some plan changes. And I'll echo back to earlier part of the conversation, which is reviewing the spread in the benefit value between the plan options and the premium spread between the plan options. I think that's something that should merit some review. And I'll pause there.
Thank you so
Perhaps
much.
even stop.
Are there any questions on what we just heard?
I have a question. Go ahead. You first.
Oh, sorry. Peggy Duncan for the record. Question for you, Chair, I guess. Would we be voting or considering taking any of these programs to like our next board meeting for consideration, or what is this discussion entailing?
So I think the idea is we'll go through each of these and yes or no to bring back additional information to the next board meeting as cost benefit. And then we'll decide at that time whether to actually implement them for the next plan year. So the first step is to what's it gonna cost or what's it gonna save? So do we wanna have that discussion in November? And then in November, we'll make the actual changes, plan to make changes.
Okay. So if I have questions about operations and how these things are going to be work or implement or other ways to go about the same problem, would that be a better discussion for the
We
next?
can have those now, I think, as we're having a discussion on each of the items, I think we have them now. And then if there's an alternative, then we would tell them to bring back the alternative instead of what they proposed. Absolutely.
Janelle Woodward for the record. When you were talking about the vision, typically, we've had to go with the voluntary option because there really wasn't coverage other than your eye exam. So are you talking about changing that and adding benefits to our normal health plan, or are you so that we wouldn't need a separate?
Richard Ward for the record, the changes as being considered here, or hesitate to say proposed, because I'm not necessarily proposing them, but these changes would be to the core basic benefit that's part of the PEB health plan. Does not consider changes to the voluntary.
Thank you.
Any other questions? Do you want a short break? Keep going.
It's fine.
Sure, we'll short break. All right, let's take 10 minutes. Let's take a 10-minute break.
Chairman, this is Radhika Kanal. I just want to say if the break is only for 10 minutes, I think we are good. I'm also going to pass on the baton to my colleague, Phil Sue. I have to be at another agency, so I just wanted to bring this to your attention. When you come back, it will be Phil Sue who would be covering your OML issues.
Okay, thank you.
Thank you.
Sure, well, I'll put on the slide and let them know we'll do that. We're back here, Wells.
Great, thank you. Okay, we'll call the meeting back to order, and I'll invite public comment on the 6 items that are in the packet that Siegel just went over regarding plan changes to bring back estimates for costs at the next meeting. Start with Dr.
Okay, thank you for the opportunity to have public comment at this time. I really appreciate that. Kent Irvin, ERVIN, from the Nevada Faculty Alliance. Regarding any plan design changes, our highest priority is to have no reduction in member benefits from the current plan year for next plan year. Our next priority is to minimize any employee premium increases. The board approved higher employee premiums for this plan year, which was option 2 at the March meeting, than were necessary for the actuary in order to avoid increases for the second year of the biennium. So we hope that still applies. We will need more clarity on the budget and reserves before any plan design decisions are made. So I hope that kind of information will either be provided at later agenda items today or in November. It took several years for excess reserves to go into negative territory, so it would make sense to replenish them over more than 1 year unless legislative funding actually has funded them. We don't know. Regarding the cross-subsidization discussion, I agree with the general idea that plan options should provide close to equal benefits versus cost, but exactly how that is defined probably needs more discussion. Average out-of-pocket costs are one measure, which were mentioned, but maximum out-of-pocket costs are another way to look at it, and average expenses are another. But addressing all that issue, the 3 plan options have diverged from the original intent, and they are no longer spread out in actuarial value as you might like. So there could be small adjustments to the 3 plan options to spread out the actuarial value while reducing cross-subsidization. So for example, the low deductible plan was the original intent was for it to be the middle plan option with a deductible. But it was changed to a 0 deductible for reasons that we don't completely understand. So shifting it more in the middle by adding a very modest deductible, say $300, might make sense. Then we just heard that the increase in the IRS minimum deductible for the high deductible plan will save the plan $500,000, which means increase to cost to employees. That's just for 1 year's increase in the minimum, and minimum has been increasing for several years now. So employees are paying that difference. I'd suggest the flat amounts per employee and per dependent don't keep up the value of the plan relative to the other plans, which may be another reason for the cross-subsidization. I'd suggest consideration at the next meeting and analysis of a new policy to make the HSA contribution a percentage of the deductible rather than a flat amount that could be 40% or 50%. And then over time, that would just track. You do the math to figure out what the deductible would be. Finally, to maintain the viability of the HMO EPO, we are opposed to get rid of that option. There was a lot of comment at recent meetings, reasons for that. But to maintain the viability of the plan, maybe it is time to look at inflationary increases to some of the copays or making small plan adjustments, but not big changes that will move migration more. The income-based employee premiums would be a really big change. It would be a more progressive policy than flat rates that we have now. So the appetite may depend on political points of view. I have not seen any data that suggests that higher income employees have higher healthcare costs. I would advise against going in that direction without very in-depth study, feedback from state agencies, and buy-in from the legislature. To help lower earning employees now, however, within the plan design, PEB could move more towards 0 premiums for the employee-only tier of the high deductible plan while adjusting the dependent tier employee contributions for dependent, the percentages, to avoid premium increases for families. So I would suggest asking for analysis to see how the math would work out for that. Finally, as an additional item, we advocate for restoring long-term disability insurance. State employees do not have Social Security disability, and PERS early disability retirement is not an income replacement program. Everyone is one accident or diagnosis away from not being able to work, not having income. Savings can run out after cancer diagnosis. About the time you go into hospice, you might get evicted. We need long-term disability insurance. Our employees should be protected. There may be vesting requirements or other adjustments that could make it more cost-effective than the old program, and that should be investigated. So those are some of my ideas. As far as the individual ideas, other individual ideas that were in the packet, fine, do the analysis, see whether there are reasonable savings without hurting employees. Thank you.
I will go to the phone line now.
Doug Unger, do you have permission to speak?
Yeah, Doug Unger, DOUG, immediate past president of UNLV and Nevada Faculty Alliance and member of the UNLV Employee Benefits Advisory Committee. I just want to reassert that looking at the EPO HMO elimination is going to produce very, very vocal and loud pushback especially from our members in the South who rely on it and who are very comfortable with that plan and will want to do anything to keep it. I also want to speak specifically to the proposal to scale income premiums. I've looked very closely at the University of New Mexico, and I note that New Mexico was mentioned in the proposal for this. The universities in New Mexico are separated out from other state employees, and they have their own state health plans. They do have premiums scaled to income within that subgroup, but they also have their own specific plans that are privileged for the university, like Lobo Care, which is connected to the University of New Mexico Medical School. At NSHE, there has been in the past talk of what it would look like to separate out that group of employees and actually go after our own plans. And I think if you scale the income across the whole state, what that's going to do is burden NSHE employees who will tend to have a higher income to subsidize lower income state employees who are in a totally different salary market. So I would take a look very, very carefully at the possibility of doing this. I personally would be in favor of an NSHE divided or separated out scaled premium system similar to what exists at the University of New Mexico. But I think there will be tremendous difficulty in fairness, in just pure fairness of this kind of scaled income premium design if higher paid NSHE faculty are subsidizing the healthcare for all the other state employees. So the question would be, is it possible to separate out subgroups of employees if one is going to consider scaled income premiums? Thanks very much for taking these into consideration, and thanks for the opportunity to make public comment at this time.
Thank you, Dr. Unger.
Yeah, that was it, Chair Wells.
Okay, that's it for the public comment. We'll close the public comment component. I think what the best course of action is to look at each one of these individually and vote on each of them individually. So starting with the medical pharmacy coupon program. And again, today we are voting to have Siegel look at cost and or savings that are associated with each of these items. And then if there are any other items, once we finish these 6 or so, that board members are interested in having Siegel come up with a potential cost for the November board meeting, then we will discuss those at the end. So looking at the medical pharmacy coupon program, is there interest in the board to have Siegel look at what this looks like for a 2026-2027 plan year change. Anyone? Member Duncan.
Kagan, for the record, can I ask a question, Siegel first?
Absolutely.
And I'm sorry because I probably missed this. I know I missed this. You had mentioned that before the CDHP was not eligible for this coupon program. But I believe you mentioned that effective a certain date that they might be eligible. Was that, when was that again? What were those dates?
In talking, it's UMR's program, so I want to. Previously, operationally, there were limitations that prohibited it being applied to the CDHP plan. And they've indicated that beginning January 1st, 2026, that the program can be applied to HSA qualified plans like the CDHP plan. So based off of that, there's the expectation that it'd be fully operational for all three plans.
What were those operational concerns?
I will defer to UMR.
I think it was the primary concern was the before deductible and after deductible and how we would do that operation. So. Yeah.
So in the CDHP plan, drugs are subject to the deductible, and in the other plans, there's first dollar coverage generally. And so that differential was an operational hurdle. Is that fair?
Right, that's correct. It only had to do with plans that had the deductibles.
Okay. And operationally, so this is going to be for inpatient drugs. So we're talking about patients that have been hospitalized and the medications that are administered to the patient during their hospitalization. Is that correct?
Correct. It could be any drug billed through the medical plan.
Yeah.
Any drug billed through the medical plan.
So somebody could do it on an outpatient basis, but it'd be physician administered. Think of like infusion.
Right.
Somebody
right.
might not
So-
be admitted, but it's different than going to a Walgreens and and walking out with a prescription. So it's the other medications.
Right, and an outpatient clinic infusion, I mean, that makes sense that, you know, there's many manufacturer programs and such that run for that. But on an inpatient basis in which, you know, there might be an involuntary hospitalization, then, you know, when does this coupon situation occur? Because that member may not have an opportunity to decide what medication is going to be administered to them into a hospital. So the Save On SP program, right, it works as that if that medication is a part of that program, there is an opportunity for a discount. The discount is obtained, the patient goes to a pharmacy, you know, outpatient basis to receive said medication at whatever lower price, right? So on an inpatient basis where there is no voluntary choice, what does that process look like?
So this is an opt-in only program, so the member has to opt into it. And we can bring some of those operational details to the November meeting to talk through a lot of these specific questions you have. But it is an opt-in program, so the member has to opt into it.
I also might add, and I'll keep my eye, because it's not on them, because it's not our program, but the intent and the application here is there's an opportunity to reduce costs for the member in the plan. And it's not the case that the cost share would be higher if they don't do it. It'd be whatever it is today. So if someone doesn't opt in, then what they pay, what their cost share is the same as it is today. And I don't think there's really any impact in what the providers are, what the course of treatment is.
Questions? How about a motion, yes or no?
Mr. Town, I'll motion to bring this to November.
We have a motion to have Siegel bring this back to the November meeting for consideration for plan year 27. Do we get a second?
Jennifer McClendon, I second.
Motion and a second. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. Move on to the next one, which is the prior authorization for biopsy coverage, removing the prior authorization for biopsy coverage. Questions, comments, motion? Dr. Schmidt.
Kate Duncan for the record. And this is just generally because I think, you know, these two options are interesting, but it sparked an additional thought was, you know, have we taken a look at prior authorization approval rates for other diagnostic or preventive services that might be nearing, you know, 100% approval that we might want to include in this list?
I will defer to our UMR partners. This was their suggestion, so.
Yeah, because every year when we do the MPD review, we refer to our show UMCM team to offer recommendations or changes to the prior auth list. And this was a recommendation from them this year, but we can certainly ask them to do the same kind of analysis for other services that are on PEB's prior authorization list.
I would be interested, Chair, in seeing this item back, maybe like with an additional recommendation of those that might be also at a similar 100% approval rate. Would that be possible?
So you want to make a motion?
I was just part of the discussion.
I think that's fine.
I can certainly make one.
Sure.
I have a question before, because I'm not sure if the motion is about to consider these two items.
Single,
the same-
we're just doing the prior
separately or,
authorization.
okay. Then I have a question for the second one after.
Okay. All right, so you want to try a motion?
Okay, so Kate Duncan for the record. I would move that we bring the removal of the prior authorization for biopsy coverage back to our next meeting with an additional review of other prior authorizations that might be nearing the 100% approval rate.
Okay, we have a motion. Do we have a second?
No, we'll go to second.
Okay, we have a motion, a second. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. Next one, covering diagnostic breast imaging and colonoscopies at 100%. Member Harper, I think you had a question.
Yes, Blaine Harper for the record. Considering that this coverage would be subject to the deductible and the CDHP, could a cost estimate be provided for, you know, what the cost upfront to those CDHP plan participants would be?
Yes, we have it in the data, what's deductible and what's co-insurance.
Okay.
So the proposal would be the co-insurance becomes 100%.
Okay.
So to remove and eliminate member cost share to the degree possible. So right now, it's subject to, if the member hasn't hit the deductible yet, then it's subject to the deductible. And then any amount above that is subject to the co-insurance in the plan.
Right, so my question is oriented for a hypothetical plan participant who has that potential cost come up early in a plan year and they have not met the deductible. Is this kind of cost something that would hit the deductible right at the start of the plan year, or?
I see, so you want a straw person kind of example to make it a.
Right, just what's the
Sure.
impact to that participant?
Yeah, that's easy to do.
Any other questions regarding this one? Do I have a motion on this one?
Motion to bring it back in November, Blaine Harper for the record.
Okay, we have a motion to bring back diagnostic imaging and colonoscopies at 100% for the next meeting. Second,
Janelle Woodward, I'll second.
motion in a second. All those in favor say aye.
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 Any opposed, nay? Motion carries. Steerage and member education for using a non-network lab. Any questions on this one? Motion on this one. Balance is golden.
Our motion to bring us back also.
All right, so we have a motion to bring the member education. So do you want it to be first of the year, first?
Can they estimate both? I mean, can it come back with an estimate for both?
So we have a motion to cover non-network lab cost share for both the first time ever and the first time for a plan year. Do I have a second?
Janelle Woodward, I'll second.
Motion and a second. All those in favor say aye.
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 Any opposed, nay? Motion carries. Vision updates. Adding hardware coverage to the CDHP, increasing the current $100 annual limit to align with the market, and an implementation of a vision provider network. I will say we had a vision provider network at one point. And it just went away. It wasn't worth the price that we paid for it. So just throwing that out there. We have had one in the past. Motion on this one?
Question on that for you. Janelle Woodward, for the record, you're saying that we had one in the past, but it wasn't worth the cost of it for the network.
So most networks have a per member per month fee that we pay to the network to get access to their providers. What we found was that not enough providers were on that list to warrant paying the price of the list.
So what would be our options then? On this question was, is it the member or the asking for a network, or I forget.
Yeah, so there's three pieces of this one. There's adding the hardware coverage to the CDHP to make it to align it with the low deductible and the EPO HMO plans. Increasing the current $100 limit, so you get $100 maximum reimbursement to kind of align with the marketplace. And then the third component of this was to bring in a proposal for a vision network.
So I'll make a motion.
Okay.
To bring this forward to November without the network. Can I do that?
Yep. You can make any motion you want. So we have a motion to add hardware coverage to the CDHP to align with the LDH, the low deductible EPO and HMO, and increasing the current $100 annual limit to align with market. Do I have a second?
Second, Blaine Harper for the record.
Motion and a second. All those in favor?
Aye.
Aye. Any opposed, nay? Motion carries. Next one is co-pays, increasing the non-preferred brand cost share from $75 to 30% co-insurance with a minimum and maximum to incentivize generic and preferred brand utilization. Do you have any questions, comments? This one, Dr. Dunn.
Keiko Duncan for the record. So just question about the min max. If we were to bring this back in the next meeting, would you be presenting different options of that minimum max and the
Yes.
cost impacts? Okay.
Richard Ward for the record, yes.
Okay, and never mind. So it's too complicated.
And we would come back with specific options for the 3-tier specialty as well.
Okay. We're just talking about the first one right now.
Right now. Any other questions from board members? Motion?
I'd offer a motion to bring this back to November, the potential 30% co-insurance with the min-max, and the options therein.
We have a motion to bring that to the next meeting and a second.
I'll second Joy Gormer for the record.
We have a motion and a second on increasing non-preferred brand cost share from $75 to 30% co-insurance with a minimum and a maximum. Back to the November meeting. All those in favor say aye.
Aye.
Aye. Any opposed, nay? Motion carries. Next one is to implement a 3-tier specialty copay structure. Any questions?
Kaker Duncan for the record. I definitely understand where biosimilars would present a significant cost savings. I'm curious if the reason why we are targeting biosimilars is because, actually, let me say it differently. Did we all, like, have we also considered targeting specialty drugs as an entirety, or was it focused on biosimilars because there was a, astronomically greater savings, or like what was the reason for this focus?
Richard Ward for the record. The biosimilars are our alternative to traditional specialty medications. And so I consider this proposed approach does target both. Maybe I'm not understanding the question.
Yeah, so biosimilars are, they are still specialty medications, at least those that there are biosimilars for. It is just one such category of a specialty drug. So I'm curious if there are other therapeutic classes that fall within the specialty category that we've potentially, considered a cost savings for example, like HIV, right? There's a significant amount of generics that are out recently. Like, has that been evaluated, or are we targeting biosimilars in this offer specifically for that cost savings?
So Shelley Chen for the record, I think to address what Richard was saying is that by doing this 3-tier analysis, we could look at, across the whole specialty class, being able to tier not only, the biosimilars, but preferred versus non-preferred specialty products. Because right now at a single copay for all of them, there's really no incentive to choose one over the other.
Right.
So that we can look at it across all specialty classes.
Clean Harbor for the record. A general question on biosimilars, because I'm aware of enantiomer differences between brands and generics that come up sometimes. So is there a possibility that introducing biosimilar alternatives will increase pressure on consumers to change well-established medication regimens?
I'm going to defer to our Shelley. Do you want to come up here? I have a feeling that's not the last question.
So Shelley Chen for the record. I think the ability for the patient and prescriber to ultimately, determine what's best for them is still going to be in play. So the copay tiering is really just to help incentivize, if there is an alternative, a lower cost alternative that is available, lower cost to the member, lower cost to the plan. But ultimately, if if the patient has already been on a medication and is stable and they want to stay on it, that is still an option. There's just essentially, and it's really to the formulary also to address the formulary. If it is a formulary covered drug, that it's still available, but now there's just optionality in the copay tiers based on, what ESI can negotiate for lower costs alternatives.
I would expect that there'd be an exceptions process for clinical reasons, like you have with traditional medications where you have steerage already. If there's a reason that the non-preferred brand is necessary over the generic, whether it's maybe someone is allergic to an inert ingredient or it works better for whatever reason, then there's a process to care for that. I would expect that would be part, right? Okay.
Thank you.
Kaker Duncan for the record. So I imagine if we did a cost, a fiscal impact for this, then it would, you would be able to, I guess, provide a trend or a estimation of costs for potential increase in prior authorizations?
We would do this would be in conjunction with ESI, where we would anticipate a broad impact analysis. So it'd be financial, it would also be from the member's perspective, and it would include the impact on the member's cost share, the member's experience, and then the process for the members. So I think all of those things. And we identify the medications that are currently being utilized. And so it's not just strictly a dollars and cents analysis. It's on the experience and access as well.
Shelley Chen for the record, and I think we could probably get from ESI maybe an estimation from their book of business, like how many people request essentially a copay or a tier waiver or, a request for.
If I could, this is Amy Donahue for the record. So there's just a few high usage biosimilars. It was Humira last year, and this year it's going to be Stelara. And not a lot of patients on those, but there was a high acceptance to the biosimilar. So this is really, I think, future thinking, if you will, and that as the wave continues with these high cost specialty medications, that you're set to achieve the dramatic savings between the originator and the biosimilar.
Any other questions? Do I have a motion?
I would like to motion. Yes. I would like to motion to bring this back to the next meeting as a two-part impact analysis. To bring back the analysis if we were to develop the 3-tier specialty copay structure for biosimilars only. And secondly, if we were to develop a 3-tier specialty copay structure for specialty drugs, all inclusive.
May I comment?
Absolutely.
Okay, Richard Ward for the record. Some of that is already occurring by formulary management and also determining and ESI determining which drugs and which medications should be on the specialty list versus not. There's not a uniform industry-wide definition of specialty versus not. So some of that is already I would expect is already considered as they review and update periodically the formulary list and the specialty medication list. But I think conceptually, I get what you're saying.
So if that's currently being managed formulary-wise, that means, and this may be wrong, so correct me if I'm wrong, that means that we are deeming potentially a brand name specialty drug under the specialty copay tier, and it's generic under the generic tier 1, 2, 3 tiers.
Shelley Chen for the record. So currently you're saying Humira with the biosimilar for Humira is being charged a non-specialty generic copay tier? Is that what you're asking?
Yeah, but I'm asking where do they currently land then? So if you're saying that the generic of a specialty drug is not technically classified as a specialty drug, where is it currently being classified?
I think it is being classified as specialty. So right now, all the biosimilars, reference brand products, and all by designation, ESI's definition of specialty, it's falling under the specialty copay tier, which is a single Right.
But they may
Okay, so-
change the definition of a medication from specialty to non-specialty, and then it would fall into the 3-tier.
Okay, so we've established that for biosimilars, a biosimilar and its reference product are both currently under the specialty tier. Okay, so let's not talk about biosimilars. So for any other specialty drug, for example, like HIV medicine, if that brand name is its brand and generic also similar to the biosimilar concept, are they also both managed under the specialty drug tier? Or is the generic moved elsewhere? Because that's what I was gathering from your comment there, is that the generic drug is
No,
moved
they would both be
elsewhere.
non-specialty. It wouldn't be specialty and generic. If that scenario, in that scenario, the medication, the specialty medication would be moved from the specialty list to non-specialty. In that very specific case.
Just and Shelley Chung for the record, HIV is a little bit confusing because not every PBM defines HIV as specialty versus non-specialty. There are some differences, and I can't remember how it's defined for PEP, but say like an oncology medication. So oncology drugs are typically considered specialty, but you have like brand Revlimid, we have now generic lenalidomide. The generic lenalidomide, even though it's an oral product, it's still considered specialty. So it's still going to be the same flat specialty copay versus peeling it out and considering it non-specialty for some reason and putting it through that, giving it a generic copay.
Yeah, exactly. So that's what I'm talking about. So other specialty medications, it's brands that have generics available that could be also significantly, reduced in cost to its brand product as of today are all under a single flat rate specialty copay. Right. Okay. So the concept that I'm trying to get at with this motion is there potential savings for our recipients and for the plan if we were to explore this as a specialty drug copay entirely? And yes, like there would be a process in which we would have to establish that specialty drug, let's say, quote unquote formulary, if you will. It would have to be a list, right? It's a specialty drug list because yes, you are correct. There is no industry standard specialty drug list. There are best practices and those that are often categorized in such a way that could be utilized, which I assume the expertise of the plan and yourselves would be able to differentiate. So that's why what I would look to see next meeting would be an offer of proposal if there would potentially be savings one way or the other.
Yeah, Shelley Chen for the record. I think we can do it as essentially one. I think you had said originally, could we do it as two separate analyses? But I think if we do it as one analysis where it's a three-tier specialty copay design, and in the tier one would be biosimilars and generic specialty drugs. So I think it would keep it simpler, and it would make sense to do that across the board. Unless you really think there's a need to have two separate analyses for just biosimilars and then all other specialty generics. I think
Well, I mean, and please, the rest of the board, chime in on your thoughts here. The only reason why I would ask for it separately is I think it's a very well-known, concept today that biosimilars have, can present an extraordinarily significant cost reduction. And we're seeing that, in our other plans, like in Medicaid, right? So if we wanted to target just biosimilars exactly and say we maybe not, we don't see a cost benefit to doing all specialty drugs. When you guys bring back that option, maybe we could pivot and simply vote on biosimilars alone. That's the only reason why I continue to bring that up separately, as this was the original idea.
Okay, you have clarification. You want to keep your motion separate?
I'll keep that motion, yes.
Okay. Do we have a second? So we have a motion. Do we have a second?
Jennifer McClendon, I'll second.
Okay, we have a motion and a second to implement a three-tier, have the Siegel bring back a three-tier specialty copay for biologics only, or biosimilars only, and then for all specialty drugs. All those in favor say aye.
Aye.
Any opposed, nay. Motion carries. Next is income-based premiums. Any discussion, questions? Motion?
For the record, I'd like to have follow-up at the next meeting with an assessment of existing plan choices, what incomes are associated with participants in each plan, if that's possible.
We will have to crosswalk between a couple of data sets to do that. I actually had written that down in my notes earlier, that would be something interesting to investigate. So I don't, Richard Ward for the record. So I don't know how feasible it is, given the data that we have currently and the timing of that.
Yeah.
But if we can do it, yeah.
Like Harper, for the record, I think it would be worth a greater depth of study than sort of the next meeting time horizon. So if there's the possibility for slower consideration, I'd appreciate follow-up. But I don't see November as a requirement.
Yeah, Nick Proper, Operations Officer for the record. We don't have that information. We don't have interfaces with every board, commission, local government agency, so we would not be able to provide that by November, probably not even December, January. We would need to get interfaces with everyone built up, file conveyed, then there's technical costs to get that. So yeah, we do not have that.
Jennifer McClendon for the record. I'm not opposed to looking at income-based premiums, but I would have a preference, and I don't know if it would go here or be separate motion, to look at what was referenced earlier in the presentation about having a free potential, like, so for the high deductible plan, what would it look like if we offered the high deductible plan to the employee only at a $0 cost, and then spread the costs out over the other plans? Like, what would that look like in terms of distribution as opposed to income-based?
So we can look at that as part of the Appendix A discussion.
Okay.
That's where you're gonna do your
that where I got-
subsidization components. So we can look at it as part of that.
Thank you.
Keiko Duncan for the record. You had mentioned some other states that have already looked at doing means-based premiums and such. And I'm curious if in those other states, or, you know, with your expertise, there is an anticipation, no, that's not the right word. If we would anticipate any more migration between plans, or migration of that thought just went out one ear out the other. What was I gonna say?
Can I anticipate the rest of your question?
Yeah, go ahead.
Okay, Richard Ward for the record. Yes, there would be, so consultant answer is, it depends. So the bigger the change, the more migration you're likely to have, and that would be either between plans, or were you thinking perhaps between single and family as well?
Potentially.
Yeah, so sometimes when we look at it with public employers, there's not a lot of spread between income levels for the majority of the employees. So it's maybe not worth the effort once you look at it, because there's just not gonna be as much spread as you might see with private employers. And so that's a consideration, is how steep do you want that? And you can manage that, the steepness of that slope with the design. But oftentimes you end up with a lot of employees within the same salary range. And so then maybe it's not worth it. We often see it being considered when there's going to be a significant increase in employee premiums. And then the thinking is that the higher earners are more, it's more easily absorbed by higher income employees. and soften the increase for lower employees. That's off, or lower paid employees. That's often the situation that this comes up.
In these other states, did any of them conduct a like a salary assessment of sorts? Looking into like the appropriateness of pay that these state employees were currently paid, you know, based on yeah.
So, Richard Ward for the record. The other states that I'm familiar with that have income-based or have means-based premiums, it was not, that change was not in conjunction with a salary study. But states do perform salary and compensation studies periodically. So I can't say that it wasn't, there was no consideration, but the ones that I'm familiar with, they didn't happen jointly.
Questions? Motion?
Blaine Harper for the record, not a motion. Just an observation I wanted to share. And this may vary between employers within NC, where I work at the University of Nevada, Reno. The fringe rates are significantly higher for classified employees compared to faculty. And one of the driving factors in that difference, because it's expressed as a percentage, because PEB is a flat cost, that is a main contributing factor to the difference in the fringe rate. So there may be approaches that are outside the scope of the PEB board that are relevant to the discussion, but that it's not so much a change in plan premium design that would be involved.
Other comments, questions? Pass. Motion? Okay, not hearing a motion, so we will not be doing income-based premiums.
Do you still want us to put some thought into the analysis that you requested? Just conceptually, like how it could be done? And come back, or should we table that as well?
I think for now, I think we table this. I think that this is a longer term discussion. I think because I think the legislature is gonna have to weigh in on whether they would be willing to move this direction.
Yeah, it's very much a policy.
Mr. Carson, for the record, I would also say as the Nevada Health Authority moves forward to model different possibilities for joining contracts, that this might come up in that analysis, and so this might be a longer term consideration than like a plan year 27 consideration.
Okay, the last of the recommendations from Siegel to address is the viability of the EPO HMO or alternatives. Comments, questions? Okay, no comments, questions? Any recommendations, motion? Very done. So we'll leave the EMO or EPO HMO plan as is for the November discussion. Anything else the board would like to discuss and have brought back by Siegel at the November?
May I say something? Okay, Richard Ward for the record. It just occurred to me, it may not be as clearly stated here, but the intent of here is for there to be two options. One is specifically to sunset the EPO and the HMO, and then the other is to consider changes to the plans in general. So changing the deductibles, reviewing the actuarial value and the spread between the different plans. And I consider those to be separate considerations.
So if I go back, I'm gonna ask a question. Nobody else wants to ask a question. So if I go back to the actuarial value of on the first, and second page of the design, the CDHP is an actuarial value of 76, the load deductible 85, and the EPO at 89, and the HMO at 91. So the EPO and the HMO are, I mean, they're relatively similar. They're not identical, but they're relatively similar. But I agree that there's not enough differential between the low deductible plan and the EPO, and too much of a difference between the CDHP and the low deductible plan. And it's kind of gotten away from what it was intended to be, which was that middle ground tier. And I think what you're seeing, and I've said this before, I think that the actuarial value has gotten too high. The premium has not kept up. So that's why you're seeing the migration, is that people are not seeing a reason to stay in the high deductible plan anymore, because there's not enough premium differential, and there's a significant actuarial value dip. And so I think that we need to look at moving the actuarial value of the low deductible plan down so that it is more back in line with the original mid-level tier. I don't know exactly what that looks like. I don't know if it's an increase in the or in reintroduction, I guess. There was a deductible at the beginning. If it's a reintroduction of a deductible, or if it's a change to the copay structure, but I think that we need to look at something to move that back to the middle.
Richard Ward, for the record, I would think along the same lines.
So any other discussion on that proposal from board members?
Lynn Harper for the record. The prior years of PEB plans aren't all posted on the website. Would it be possible for the members to receive the information about the plans going back to maybe plan year 2016 to see how things have evolved over that time period?
So the low deductible was reintroduced in 22. So before that, it was a CDHP and the HMO EPO. There have not been significant changes to either plan, either of those two plans, since they were introduced in 2011. So it's really the low deductible plan that was reintroduced in 2022. So we don't need to go back to 2016. But you're talking about the plan design, not the premiums.
Right.
And I don't think there's been much change other than the elimination of the deductible.
22.
No, it's been pretty stable.
Yeah, I think that, and I can't remember exactly what the deductible was, but a couple hundred.
I want to say it was 100.
Yeah.
It was not a significant deductible. I think that's really been the only change, was the elimination of the deductible. Since since the PPO was reintroduced. So I don't think any of the copays have changed. And if they've changed insignificantly.
And we have all the plan documents back to 22 on the website. So everything's on there. 22, 23, 24, 25 is on the website.
I would also, if I may, Richard Ward for the record, I would also suggest taking a look at the max out of pockets as well. You may decide not to do it, but when we were looking at some prospective plan changes prior under a similar scenario of sunsetting the EPO and the HMO or a redesign of them, the fact that the max out of pocket for the EPO is higher than the low deductible health plan, and it's supposed to be a more generous plan that results in some barriers in making adjustments to the plan designs. So we could come back with some benchmarking information. We did a Western state benchmarking a year and a half ago. We could refresh that just to provide some context of how these plans compare with other state plans in the West. And then you can decide whether to do anything or not.
Motion to have Siegel bring back the West Coast, what do you call it, West Coast?
It's the Mountain West states primarily.
Mountain West comparison, see where our plans rank. And then we can decide whether to do anything with the low deductible PPO plan.
Okay, Duncan, I'd make that motion.
Okay, we have a motion, you have a second?
Jen McClendon, I'll second.
We have a motion and a second to have Siegel bring back some Mountain West states comparison of our plans for the purposes of looking at the actuarial value of the low deductible PPO plan. All those in favor say aye.
Aye.
Any opposed? Nay. Motion carries. Okay. Anything else? Going once? Twice?
Anything else, period, or?
Anything else as it relates to benefits that we would like to look at for November?
Janelle Woodward for the record. We cut a lot of things out with COVID. I would like to see us look back and see if there's anything we can do about things that were cut to bring them back for the benefit of employees. It may not be possible within the constraints that we have financially, but I think it's worth a look.
I don't know, I couldn't tell you to tell you what, I mean, you have to be more specific.
So like
LTD, that's about it, LTD.
So long-term disability specifically.
So LTD was a fully insured product at the time. That was not self-insured. So, I mean, can we get the quote?
We have a voluntary, but you want it to just have a quote, how much it would cost? Yeah.
That's what she's asking.
Yeah. Yeah, I mean, Siegel did that, and the cost of how much it eliminated during the COVID cuts was very high for the amount of people that were using it.
Yep, make motion.
I make a motion, Janelle Woodward for the record, I make a motion that we get a secondary quote on how that would affect PEP.
Do you have a second?
Second.
So we have a motion and a second to evaluate the cost of adding long-term disability back to primary coverage. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. Anything else? Okay, with that, we will close agenda item number 8. Let's move on to agenda item number 9.
For the record, Teresa Karsten, as you can see, the report addresses the operational budget as of September 30th, 2025. And this report includes the budget status, budget totals, and fiscal year 25 year-end totals. Shown in the table below is a summary of the operational budget account status of September 30th, 2025, with comparisons to the same period in fiscal year 20, I think that's supposed to be 24. The budget status is reported on a cash basis and does not include incurred expenses and income owed to the fund. The budget status report reflects actual income of 129.2 million as of September 30th, 2025, compared to 127.9 million as of September 30th, 2024, an increase of 1%. Meanwhile, total expenses for the period have increased by $25 million or 19% for the same period of time. The budget status report shows realized funding available at $61.4 million. This compares to $112.7 million for the same period of the last year. The table below reflects the actual revenues and expenditures for the period. With the change in fiscal staff and integration into the Nevada Health Authority, a new budget tracking system is being implemented to improve the process and provide consistency across the department. Detailed budget projections will be provided once the budget tracking system has been fully implemented. No recommendations for this at this time.
Questions from board members? Close agenda item number 9, move to agenda item number 10, contracts. Presentation and possible action on the status and approval of new PEB contracts, contract amendments, and solicitations.
Teresa Karsten for the record. 10.1 contract overview. The contracts with Capital Reporters has currently expired, and PEB staff are working to secure bids for an informal solicitation for court reporting and transcription services. Discussions with purchasing are being held in relation to the possibility of an extension for pharmacy benefit management services, which an update will be reported on during the November board meeting. 10.2 new contracts. PEB does not currently have any new contracts for ratification. 10.3 contract amendments. PEB currently has 2 contracts that expire in approximately 8 months. Each vendor has agreed to continue with current pricing if the contracts are extended, and each contract allows for a 2-year extension. PEB staff requests approval from the board for amendment to extend each contract. No other changes are listed in the amendments. Recommendation is to approve the extension of both contracts. Status of current solicitations. 10.41 is for our benefit management system services, which are currently in the negotiations phase. PEB is working with the Division of Purchasing to execute the final contract. I know.
Any questions? I get a motion on the 2 contract amendments for HSA Bank and United Health Insurance for Basic Life to extend them from June 30, 2026 to June 30, 2028.
Janelle will do it for the record. So moved.
Motion, do I have a second?
Jim Barnes, second.
Motion and a second to amend the HSA Bank and the United Healthcare Insurance for Basic Life Insurance from 6/30/26 to 6/30/28. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. Close agenda item number 10 and move to agenda item number 11, the executive officer report.
Teresa Karsten for the record. Item number 1 is a staffing update. PEB currently has 34 positions in our budget account. Currently, there are 3 vacancies. The vacant positions are administrative assistant positions with our member services unit, 1 accounting team member as well. I believe that brings our vacancy rate to 8.8% or 9%. The second item is the cyber attack update. On August 25th, 2025, PEB was closed due to a statewide government response to a cyber attack. During that following days, PEB staff were on administrative leave there were a couple of employees that were working from home to assist members that were asking questions through the PEB portal. By August 28th, staff returned to the office as internet and phones were back up. The cyber attack had minimal impact on PEB as files were saved to our cloud server and accessible through internet access. Another contributing factor for the minimal impact to PEB is that the system portals used for business processes are hosted by third-party vendors who had not been impacted by the statewide outages. Item 3 was plan migration from year over year. This was requested by a board member. So as you can see in the table below, from enrollment from plan year from end of 24 into the start of 25, that shows CDHB totals and EPO HMO members moving out of those plans. Similar occurs at the end of plan year 25 into plan year 26. So those totals are presented here for your review pleasure. Item 4, reserve balances. This is the information that we have from our budget and work program. So we have in the first column what was presented to us as the amounts for each of these reserve accounts based off of what's in board policy and what has been provided to us by Siegel. Then what was in the budgeted amount versus what was actually funded, and it shows the deficits to each of those reserve accounts. The total difference is $251,554. During previous public comments, there had been mention of this, so we wanted to make sure that we presented this for any additional questions or concerns by board members. The estimated IVR reserve was 57.5 million, and funded at 62 million. Thank you. The catastrophic reserve were advised to be budgeted for 46.5 million this year based on the 45-day of the projected total incurred claims for fiscal year 25. PEB budgeted 49 million for the reserve account, and the final approved budget is 42.5 million. Finally, the HRA reserve must maintain the 80% of the available HRA balances. The remaining balance for fiscal year 25 is 2.4 million, and the balance for fiscal year 26 is 19.5 million. 80% of these balances is 17.5 million. PEB budgeted 29 million, and the allowable funding was 25 million. Next is an update for Carson Tahoe. Carson Tahoe and UMR have entered into contract negotiations to extend participation into the PEB network through June 30th of 27, I believe, is that right? Thank you. I'm seeing a head shake, yes. Final contract amendments have not been completed, but are pretty close. And if you have questions, UMR is here to address that. Both parties will be either reporting out on a completed amendment by November or providing communication to where they are at in that process, so that members of the Carson Valley have access to services. And then this other paragraph is just addressing some of the public comment from the July meeting, where it had been alluded to Carson Tahoe refusing treatment of PEB members. We worked with our staff to look at our member services call center logs, as well as our appeals and grievances reports, to ensure if any of those reports had been made to us, that we worked those. At the time of that review, we had not received any of those, and we do not have them to date. We did hear about a misunderstanding where Carson Medical Group was communicating that Carson Tahoe was not doing that, but that was in fact not Carson Tahoe refusing services. And then for possible action, we have the HPN large group medical loss ratio premium rebate. Attached, you will find the memo prepared by Siegel to address the premium rebate amounts and considerations for refunding members. At this time, I'd like to recall my recommendation that's currently here. There's been several discussions with Richard Ward and Siegel staff about updates that they've received since I have posted this. And so after, I'd like to call him up to address any of those new sets of information so that we can have a discussion. And if you have questions at that time, I can revise my recommendation. Thank you, Richard.
Sure. So the total dollar amounts cited in the memo are unaffected. So the full rebate is still the, how do you think I could read? Where is this? The full rebate is approximately 900,000. And there we go, on page 2, 891,000. I'm under the current rebate header. And then using a pro rata calculation based off of the portion of the premium that's paid by the member versus PEB, that's about 29%. That results in the total rebate that should be returned to members of 257,000. And then there's some options in how that can be accomplished. The law requires that amount, that rebate be shared. It was earned. Should I provide some background on this? Yeah, okay, I'm sorry. Let me back up. I'm sensing the clock ticking here, so I'm jumping ahead. Okay, so this is a provision from the Affordable Care Act that requires insured medical plans that have essentially too fat of a margin to share some of that margin with members, with the policyholders. And so the threshold is the medical loss ratio of 85%. And what that means is that if less than 85% of the total premium collected goes to claims, then the difference to get to 85% needs to be shared with the policyholder. And the HMO in PEB is the only insured plan. And Health Plan in Nevada has been reporting that the HMO has claims that exceed an 85% loss ratio, but the PEB HMO is pooled with other risk and other policies. And that larger pool came in under 85%. So Health Plan of Nevada is saying they owe PEB 891,000. That's the difference. Then PEB as the policy holder, the group policy holder is obligated to share a portion of that, a proportional portion of that to members in the HMO. You can only share it with the HMO membership because that's the insured plan and that's the group that contributed to this rebate. And that dollar amount in total is approximately 257,000. There are a couple of ways to go about providing this refund to members. And the statute incentivizes doing so as expeditiously as possible. And so one way, and I'm not going to comment on how easy any of these are necessarily administratively, some are easier than others. You could cut a check and pay everybody out that's in the HMO currently. That's something I didn't say, is that this is it's applied to the current membership or future membership, depending on when you determine to provide the rebate. So you could cut a check to everybody that's in the HMO right now, and that amount would be about $79. It depends on how many people there are, so it could vary by a couple of bucks when the calculation is actually done. Another option is to reduce premiums for some period of time. So you could just do that uniformly for a couple of months, or for the next plan year, you could do it. And if you do it over a 6-month period, like if you did it from January to June, for example, the rest of this plan year, it's probably about $13 per subscriber per month. If you did it over a full plan year, it's somewhere between $6 and $7 or $8, depending on how many people are enrolled at that time. The longer it takes to complete the refund, that will incur an interest payment or an interest component to it. If you don't provide the refund within 3 months of receipt, then anything that's paid after that 3-month period incurs a 10% penalty, basically, that goes to the members. So that's why there's some variation in what the actual amount would be. It'd be due to timing and therefore any interest that might occur, and also the enrollment at that time. So I think there's 3 options. One is cut a check. The other is, and then the other form is some sort of premium reduction, which could be over 1 month or several months. And it could be during this current plan year or the next plan year.
Teresa Karsten, for the record, keep me honest, for either of those last 2 options, because they would be beyond the 3-month period, then the 10% would apply to both of those instances, wherever if they decided to effectuate
Correct.
Reduction in premium.
Correct. So if it was over 12 months, then if it was $6.50, that would become approximately $7.15.
Teresa Carson, for the record, I would say that just for informational purposes, as you guys make a decision, our accounting team is stretched, so there will be some resource issues, like trying to cut 3,000 checks or whatever that number ends up being all at once. I would be concerned about being able to do that timely. I think it could be done within the 3-month period. The secondary option would require staff to make premium adjustments, I believe, that already exist, and making those every pay period would be an extreme burden to the current staff that we have, because we only have 1 staff member that does adjustments to our payroll systems. So issuing a one-time premium reduction would be more amenable, but it'd still have to occur over time in different pots of people. We couldn't do them all at once. And then I think if that premium reduction was applied to plan year 27, then those reductions could be set in the file for all future payrolls. So that would be like no burden at all. So that is the information I have from my accounting staff.
Questions? So I'll ask one. So there's no way to change you submit a file every month to Central Payroll and all the other pay centers. There's no way to manually change that, or even to automatically change it in the table?
Automatically change it, no, but manually adjust it, yes.
So you can't go into the premium table and change the employee share and then change it back?
Teresa Carson, for the record, from what I understand, no, but I can ask again.
Because that's, to me, is super simple. It should be whatever is in the premium table is what it's picking up to charge the members. When you send the files over to the different pay centers, if you can change the employee share by whatever it is, and then change it back, you're changing 4 numbers. Single, family, children, spouse. and you change it back.
It'd still be a manual adjustment on the accounting staff.
Shouldn't be. Cause that file is not, it's not like you sent a file beginning of the year. You send a file every pay period.
To some, not everyone. Not everyone has a file. The big ones do. NSHE and Central Payroll have file interfaces, yes. But all the small boards and commissions and things like that, it's.
But once
a
you get
different
to that,
process.
you're talking single digits, not
Right,
tens of, not that hundreds or thousands.
yeah. So are you saying change it on the logic on the back end in the eligibility system
Yeah,
versus?
the eligibility system's got a premium that every
Yes.
month, when you send out the bill, it goes and says, here's the amount that you need to take from the employee's paycheck. Change that number for a month and change it back.
Okay. I think that is, Truce Carson for the record, that is new information to me. I think staff were thinking that it had to be done in adjustment files that were sent to central payroll.
No, I'm talking about just change the premium for a month. We've done that before because we've done the premium holidays.
Yeah, we've done premium holidays. Yeah, we just need runway and, do basically a project. But that's something we could look into.
So can that be done within Truce Carson for the record, can that be done in the 3-month time period?
Dallas would have to answer that. I would say probably not.
I can't imagine. It's a 5-minute fix. For all of them except for the singles. You're literally just changing 4 numbers. And then you change it back.
Yeah, it sounds super, your explanation sounds great.
For a small group of people, right? So it
Yeah,
has to be done at an individual
But
level?
each premium that's in there is assigned, or each plan and tier is assigned an amount that you take from
So we
everybody's
do it
paycheck.
just for those that are in the HMO.
So you've got 4.
For however,
You got 4 numbers that you're changing. It will pick up, if you're a single person on HMO, it will pick up that your premium is $79 lower this month.
mhm.
And then next month it'll go back to the original. You should be able to do this super simply, other than maybe the manual.
Yeah,
But I can't imagine that
that'll be
there's a lot
smaller volume.
on those.
Okay. I asked the wrong person.
That would be my preference, because I think that automates most of it, and that way you're not writing a bunch of checks, you're not trying to do a bunch of manual adjustments that are subject to error. You put the right amount in, it's automatic, and then you just have to remember to put the right amount back, or you're undercharging.
I mean, there's also the split premium component, so we'll have to figure out, how to do that if we want to do it in one, or split the refund to both, or,
Yes. Yeah, I think the split though, for the HMO, the premium, I think is enough, you could do it in one, literally in one.
Yeah,
It's not like it's the HMO or the CDHP where you've got somebody who doesn't pay $79 a month.
right.
But was it $200 a month? So you're paying let's say you're paying $100 a paycheck. Take out 79, they pay $21 one pay period, and then they go back to paying the $100 in the second pay period. It's all done.
Yeah.
Can I get a motion?
Joy Gerber, I'll make a motion to make the adjustments within the PEB system to refund this money as a one-time premium change.
Okay, you've heard the motion. Do I have a second?
Kager Duncan seconded.
Okay, we have a motion and a second to change the premium in the PEB system to reduce the HMO premiums by $79 or the correct amount based on the enrollment for a 1-month period or in, within the next 3 months. All those in favor, say aye.
Aye.
Any opposed? No. Motion carries.
I apologize, but I have a question. Did what you just approved authorize staff to handle the non-state employer refunds? Because there's a small number of non-state employers that have members in the HMO. And so the obligation is on them to provide the refund. And we don't know what their premium share is at the local level.
Correct. So the non-state HMO people would have to we'd have to pay the employers.
Correct.
And then they would have to be told that $79. What happens if they have a $0 cost share with a participant?
They would cut them a check.
Even though the employer pays the entire amount?
You're the policy holder. So the cost share is calculated on the entire group within the policy.
But the employer, so we would write a check to the employer.
Correct.
The employer doesn't necessarily need to write a check to the participant, but they may.
I think they need to be directed to do so.
Even if they pay 100% of the premiums.
Correct, because within the state group here that y'all just discussed and made a decision on, that cost share, that cost split varies by coverage tier and active employees and retirees, and we did it in aggregate, which is permissible, which is the direction of the statute for the whole policy, to simplify it.
Okay.
I think we're talking about a single figure number of people. I don't think there are a lot.
I think you're Teresa Carson for the record. I think you might be talking about two different things though.
No, I don't think so. I think he's talking about the non-state employers. We would write a check for $79 or whatever the dollar amount is times the number of people they have enrolled in the HMO, and we would write it to some district. Or some
Direct them to
board.
pay it to their employees.
And then
is what-
and then he's saying that you have to tell that employer that the amount that they're getting has to be refunded to the individual employees.
Yes, that's what he's saying.
Yes. I don't know if I agree with, but.
That's what I was saying. That's why I thought you guys were talking about two different things.
Keiko Duncan for the record, I was just noticing in the letter in Siegel, it states that the federal regulations, and I don't know what federal regulations this is, require the rebate reduce costs for the participants. So is that maybe why, even if they have no cost share, that money can't stay with the employer, it would have to move to the recipients, is what I'm assuming is the reason?
Correct.
Okay.
And in multiple plans that have multiple employers, it stays with the plan or the participant. It can't stay with the employer. So like PEB couldn't send it to the state. It has to stay, the PEB share has to stay with PEB.
But there's no requirement for us to do anything with the employer share. Other than use it to offset.
Correct. Right. It'll bolster reserves essentially.
Okay, so I guess we probably should do a second motion to do to write checks to the non-state employers with the memo to direct them to refund the amount to the participants that they have on the HMO plan. Need a second motion.
Janelle Woodward, so moved.
Can I get a second?
Keiko
Joy.
Duncan.
Slow to the mic there, Joy. All right, so we have a motion for the non-state employers to write a check back to the employers with a memo to instruct them to repay it to the individual employees covered under the HMO only. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. That will close agenda item number 11. Open agenda item number 12, the Q4 vendor reports, the information discussion. The intent here was if there are any questions on specific report from board members that you would ask them now. Otherwise, it's just an information discussion. Any questions from any of the board members on any of the reports listed under agenda item number 12? Seeing none, we will close agenda item number 12, move to agenda item 13, the final public comment period. Public comment will be taken during this agenda item. Comments may be limited to 3 minutes per person. Persons making public comment need to state and spell their name for the record at the beginning of their testimony. Any public comment here in Carson City?
Okay, thank you, Kent Irvin, ERVIN. Thank you for your service and the productive discussions today. It's nice to see a more active board. There was a question about past catastrophic reserve policies. The catastrophic reserve was formerly known as the rate stabilization reserve, so there's a hybrid purpose. According to my records, the policy used a 95% confidence level for catastrophic reserves until FY 2020. It was reduced to 62 days in FY 21 and 22, and further reduced to 50 days starting in FY 23 in response to pandemic era shortfalls. It's unclear to me when the 45 days was approved or discussed by the board for FY 2025, but my recollection is that staff under the prior executive officer arbitrarily reduced the reserve levels in the budget reports to prevent the balances from going negative. Regardless, given the deficient reserves of over 50 million as of the beginning of FY 2026, which means negative excess reserves, there needs to be a serious discussion of reserves and actuarial best practices. The executive officer report suggests or implied to me that the full amounts have been funded to replenish the reserves for FY 2026. If that is the case, then that implies that if those are already covered by the end of this fiscal year, then there would be more money available for the plan in the next fiscal year, but that's still murky to me. Regarding changes to plan design over the past 5 or 10 years, in addition to those that were mentioned, there have been changes to the CDHP deductible in response to the IRS minimum. There were supplemental HSA and HRA contributions in some of the years. The HSA contributions for dependents were reduced to 0 for some years. The low deductible plan deductible was reduced to 0, but I believe a deductible for some services was added to the EPO, and those are what come to mind without additional research. Thank you again for your service.
Anyone come up?
We do not, Chair Wells. Would you like me to bring up the slide just in case?
Yeah, just in case.
Okay, one moment, please. For those who have joined for public comment, your name and the last 4 digits of your phone number will be announced and you'll have been advised you've been unmuted. Please slowly state and spell your name for the record and then proceed with your comments. As a reminder for those on the phone, please press *6 to unmute. Well, as that concludes public comment.
Okay, with that, we'll close agenda item 13, public comment, motion for adjournment.
Okay, good items, I moved.
For adjournment, do I have a second?
Second, Jen McClendon.
There's a motion and a second. All those in favor say aye.
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 Thank you all very much.